By the way, till the screen is projecting, Ramadan Kareem, for those who are observing Ramadan, if you want to grab anything to eat to break your fast, please go ahead and you can bring the food to the room. So Deepak, we can now see you. The floor is yours. Please go ahead.
Okay. Thank you so much, Hilal. Jumbo and Karibu Sana, to a very auspicious occasion of what we were waiting for long, which is launch of Inhertu. I think it's a very auspicious occasion, as Hilal said, for those who are observing Ramadan Kareem, and those who are also celebrating the festival of colors, like which we did today in office. Happy Holi to everyone. AC is committed towards the fight against breast cancer, and you can see that as part of our cancer care commitment, we are bringing yet another great molecule and great brand into the country of Kenya. The breast cancer fight of ours is not new. We have been working along with you because it's much more the prevalent cancer type in Kenya and in sub-Saharan Africa as well as South Africa. And the only company which having a heritage extend for more than 50 years, if some of us remember in 1970s when we launched Nolvadex, the first global approval of the first treatment indicated to treat breast cancer. And today, we are here with launching Inhertu in Kenya and still more to come. I would also say, because I have my great mentor over here, Professor Mudli, who will be joining us from South Africa, that at least we have beaten South Africa on launch of Inhertu in Kenya. So on a lighter note, Inhertu is the type of the breakthrough that is seen in the generation and has become the standard of care in all markets wherever we have launched. Because of its extensive clinical trial program, which included more than 10 clinical trials under Destiny in breast cancer alone, part of the other tumor types, and where we have provided results which are good as improving PFS for more than 4 times compared to standard of care, and a survival by 36%. And you will hear it from the experts who will be talking about it, doubling the response rates in HER2 metastatic breast cancer. Today, we are honored to have a mix of local, regional, as well as international speakers and moderators who will come together to show us how much Inhertu as a paradigm shift in the treatment. I would like to thank our speakers, Professor Mudli, Ilyas, Dr. Meli, who have been always a mentor to us and guide us from the NCI perspective, how, why, what we should be doing to supporting, expanding the Cancer Care Africa, not only in Kenya, but also in Sub-Saharan Africa. Surely, I think a big name joining us from Germany, Dr. Peter, who will be talking about his own experience and also the trials across Destiny to look into how do we really choose the right patient at the right time for the right for the deserved or looking outcomes which we look into. At the same time, I think important is to just name few. If I miss out, please my apologies. I know Professor Dr. Gladwell is here from the Nairobi Hospital, Dr. Najuki, who was with us in Nigeria for the launch of Tagrisso. Dr. Manel, with a great experience with the pre-reg importation program for Enhertu, Dr. Sitna, Dr. Andrew, Dr. Shaheen, who's been helping us in terms of looking into localization of diagnostics at Aga Khan Hospital. And here we come after EGFR journey to HER2 journey. So thank you, Dr. Shaheen, for that support, as well as Dr. Helena, Dr. Mariam, and for sure, Dr. Uma. So with this, I will give back to Hilal, but thank you all for joining us. This was what we were waiting for long, and here we are with the Enhertu launch in Kenya. And a big thank to everyone who's been supporting us. I would also like to really thank, and maybe Angeline and team can pass on my gratitude and AstraZeneca's gratitude to Health Authority of Kenya, looking at the data, the value proposition, and this drug much more than what was the timeline. So thanks to the health authorities also for supporting us and bringing Enhertu much earlier to Kenya. And then this is just the beginning. With this, we are looking forward for its launch across rest of East Africa, in Sub-Sahara, and for sure, very soon in South Africa. With this, back to you, Hilal.
Thank you so much, Deepak, for setting the scene for tonight. Today we move to a short video. It will be just 1.5 minutes. That's it. Now comes the time to introduce our first chairperson and moderator for the first session of the day, Dr. Kerry Gladwell. And it's not easy to introduce someone like Dr. Kerry because you can spend the day introducing her because of the activities and the massive experience she has. So I would like to keep it short and simple. Please, Dr. Kerry, to the stage. Dr. Kerry is a medical oncologist at Nairobi Hospital and the recent president-elect of the KSHO.
So thank you very much, Hilal. We are indeed gratified to be part of this landmark auspicious occasion. And we are also grateful to Mr. Deepak Arora, the president of AstraZeneca, who's just spoken to us from South Africa. And we are part of history where we watched the landscape as, you know, when we thought trastuzumab was the greatest discovery of the 20th century, we can now see that there is more development as we encompass and widen the scope of improving survival of our patients. There has been significant improvement, both adjuvantly and palliatively. And we thought that when we did the dual blockade, that would end there. And then we watched the conjugates coming in with the TDMI. And then, of course, now the landmark where we expand the use of HER2 blockade to ultra low and also low HER2 blockade. So my duty this evening is to introduce our speakers, and I think most of us know Professor Shan Divan Moodley, who is a renowned medical oncology from Parktown, Johannesburg in South Africa, and he has a keen interest in management of breast cancer. Many of us have heard him speak before in various areas, and he's quite interested in the clinical trials arena. So this evening, we're going to listen to Professor discussing, what the past 2 decades have given us as far as HER2 treatments are concerned. And his talk is entitled, Looking Back on the Past 2 Decades on Anti-HER2 Treatments. Welcome, Professor Shan Divan Moodley.
Hello, can you hear me?
Yes, Professor, we can.
Okay, so I just need to share my screen. Is that sharing? Are you able to see my screen?
Yes, we can see quite clearly.
Okay, perfect. So thank you for asking me to do these talks for you. I'll be doing 2 presentations. The first one will be kind of setting the stage for what's to be the ENHER2 launch. I must say thank you, Deepak, for that bit of a rag. It's a little bit of bugbear we both have in terms of not having easy access to what we need. And I'm glad that you guys in Kenya are in a position to be able to offer this commercially to your patients. They certainly deserve it. As with most of these things, there's the disclaimer slide to say that basically this is educational, and it's many of the things are my personal thoughts and personal take on some of the data, so therefore it can't be used as a AstraZeneca viewpoint. Okay. In this process, one of the first things I'd like to say is we're going to kind of go through this list of discussion points. We'll discuss the options in therapy. We'll talk about Cleopatra, Teresa, Amelia, lapatinib, and then eventually end with tucatinib, and then a little bit of treatment algorithms. Okay. There are a few therapies that are available in this process, and when I was younger, we had Herceptin, Perjeta, which were HER2 monoclonal antibodies. We then got a little bit fancier, and we got HER2 kinase inhibitors, and then both of those were Tykerb and tucatinib. And then thereafter, we've got ADCs, which are drug antibody conjugates or antibody drug conjugates, which basically was initially Kadcyla, and now the big daddy, the ENHER2, which is trastuzumab deruxtecan. All of these drugs work in different parts. Some extracellularly, binding to ligands, that's the HER2 targeted monoclonal antibodies, the TKIs relatively internally because they're small molecules, and then the ADCs also externally, but then with their payload being internalized so that they can exert greater damage in the HER2 cell. Initially, if we look at the data in metastatic breast cancer,
I think we can't hear Professor anymore.
There we go. There we go. Your host accidentally muted me. Okay, so that should be better now.
Sorry
okay?
for that.
Can you hear me?
Very well now.
Perfect. Okay, so I'm now unmuted again. All right, so in the metastatic setting, we started with using trastuzumab plus taxanes. And we found a remarkable therapeutic benefit, okay? That remarkable benefit was not only in response rates, where if we combined monoclonal antibodies, single-agent monoclonal antibodies with taxanes, we've got 50 to 60% response rates. And then this translated in the metastatic setting to survival benefits of 2 and more years, which previously were never seen. Bear in mind that before the advent of monoclonal antibodies, HER2 positive disease or HER2 amplified disease was the poorest prognosis, even poorer prognosis than triple negatives that we see today. So this is something that there we go. This is something that is not uncommon to us. Okay, with the advent of a second monoclonal antibody, pertuzumab, we then got a situation where we started having 2 monoclonals together, and they kind of binded. And the pertuzumab was a HER2 dimerization inhibitor, which prevented the pairing of HER2 with other HER receptors, in particular HER2 and HER3 dimers. So you get a more comprehensive blockade of HER2 signaling. And so what happened is the strategy came that we started combining the two in the metastatic setting. And when we combined pertuzumab and trastuzumab, we got a more comprehensive HER2 blockade. And theoretically, when you got that both being administered together, we've got a complementary effect. This was proven in the Cleopatra study, where trastuzumab and pertuzumab were combined with docetaxel and compared to trastuzumab and docetaxel in first-line stage 4, de novo stage 4 patients. And if you look at that, the inclusion-exclusion criteria was standard. And of note is that in the early years, and certainly even now, the possibility of cardiac failure and cardiac dysfunction is a significant possibility with these HER2 targeted agents. And therefore, one of the things we did is we made sure we got decent cardiac patients for these trials. And one of the things that Cleopatra showed us is that the combination provided a significant progression-free survival and overall survival benefit when combined with taxane, and particularly here we're talking about docetaxel. So we're looking at a delta in terms of OS of greater than 15 months, which is pretty huge in the metastatic setting. And we found that survival in the Cleopatra, in the intention to treat population, also bore out that benefit at an extended follow-up period of 8 years. The survival was greater than 6 months in the ITT population. Okay, I mean the PFS, and this is important to note because the ITT population randomizes patients according to where they were originally randomized, and therefore you analyze patients despite the fact that they crossed over and they may have received the combination after a period of time. They were still randomized to the originator control arm, which makes these results even more impressive. Of course, all of these interventions come at a cost. And the cost here were the adverse events, and the adverse events that we saw with a greater degree of frequency with the combination was diarrhea, rash, and mucosal inflammation. Again, none of these things would be significantly dose limiting and significantly problematic with the management of the combination, and therefore we would use this. Febrile neutropenia was a problem, but that was probably related to the docetaxel as opposed to the combination. Please bear in mind that the addition of 2 anti-HER2 targeted agents did not appreciably make a difference to the cardiac toxicity. So they were comparable between both arms. And it's the first time where people started to accept that cardiac toxicities with these agents is a necessary evil, but not a huge problem when administering these drugs. The Peru study then tested what do we do, because there were some parts of the world, particularly the US, where paclitaxel was the much preferred agent, whereas Europe would kind of use docetaxel. The US was kind of married to the Bristol Myers Squibb product. And at that point, this trial came to the fore, where it was basically in the first line setting, a head-to-head testing between docetaxel, paclitaxel, and nab-paclitaxel. And the investigators could choose which one of these taxanes they would use. Interestingly, they found that actually, in terms of patients that they used in this thing, you can see that in essence, these all overlap. The graphs all overlap. So your PFS probability in all the groups tested showed an overall response rate of about 80% and a clinical benefit rate of about 86%. And to this end, they showed that actually you could use any one of the agents. Right? The next thing in this process is that, interestingly, but not unexpectedly, the patients that had prior exposure to trastuzumab did a little bit worse compared to no prior trastuzumab. And basically what this showed is, A, there's still benefit to giving patients the combination, even though they had trastuzumab, but that not having trastuzumab before didn't preclude them from having treatment. So in summary, the combination of dual blockade plus chemotherapy and displaced docetaxel increased overall survival to 56.5 months. So another 15.7 months benefit when you add the second HER2 targeting agent. The Perus showed you that, as per safety, very similar to Cleopatra, with a median overall survival of more than 5 years, and it showed that paclitaxel was a feasible alternative to the docetaxel. And that, interestingly enough, we would treat in the metastatic setting often, giving people chemotherapy for longer than purely 6 cycles if there was ongoing benefit. It demonstrated quite clearly that giving docetaxel for more than 6 cycles had no clinical benefit. And when I'm talking about no clinical benefit, I'm talking about both in the OS and the PFS arena. Enter the first time in the HER2 space, an ADC. So TDM1 was the first ADC, which we all subsequently has grown to know as trastuzumab emtansine or Kadcyla. Okay, so what happens here is you have a trastuzumab and is bound to DM1, which is emtansine, with a non-cleavable linker. It's the first generation of ADC, and it was the first one to become approved in the scenario of metastatic disease. And as is quite normal in this scenario, when you get a new agent in a field, it's first tested against what is standard of care in the metastatic setting. And in the metastatic setting, the combination in terms of the doublet became standard of care. So the first tests with this was in the second line setting, okay? Second line being treatment with lapatinib and capecitabine, which became the de facto standard, despite the fact that the trial didn't recruit all that well and the numbers were quite limited. At any rate, at this point, Kadcyla was tested against the lapatinib capecitabine combination, which was the standard of care in the second line setting. They found that there was more than a 50% improvement in the median progression-free survival. So what that means is these patients in the second line setting were actually getting a larger amount of time where their disease was controlled without progression. So that's the first thing that said, hey, hang on a second, we have an improvement. Second thing is they showed that more tumors shrunk in these patients. I mean, the patients, the tumors had shrunk in more patients, and the delta was 12.7. So about 12.7% more patients had shrinkage of their tumors. And then the last thing is that, not the last thing, the penultimate thing is the duration of the response was almost doubled. Okay. The safety feature was that there were fewer grade 3 adverse reactions. Of course, the big problem with the combination of lapatinib plus capecitabine is the diarrhea and the PPE. Okay. PPE, plantar palmar dyserythroesthesia. So Kadcyla didn't give you those problems, but there were a couple of hematological problems, so and liver issues. So you would be aware that you would get thrombocytopenia when using Kadcyla, and you would get anemia, and you might get an increase in transaminases. So we discovered a few different side effects, and then yet we found that the toxicity over, by and large, was less than the lapatinib capecitabine combination. So TDM1 became established as the second-line standard of care in metastatic breast cancer, where patients were HER2 positive, provided they were previously treated with trastuzumab plus taxane, because the immediate trial allowed for that. It improved the PFS by 50%, improved the survival by at least 6 months. As is quite customary here, once we've established the line, we would then look to see, once the second line was established, then there were a whole lot of patients that also got therapies and were still alive after Kadcyla, after second line treatment, and still never received Kadcyla. So the question was then, would this be of benefit in the third plus lines of therapy? So the trial was taken on where, remember, at this point, we were still giving chemotherapy in this disease. And we hadn't all pure accepted that one just changed the chemotherapy and kept the monoclonal antibody. And in many parts of the world, that was not being done. So once patients had progressed on monoclonal antibody, that monoclonal antibody was stopped, and treatment then continued with different lines of chemotherapy. So Kadcyla was tested against chemotherapy, and then the chemotherapies here were chosen by the local investigators. Okay, so we would see that giving patients who had received prior trastuzumab and other combinations who had not received Kadcyla previously, even in the third plus settings, treatment still is associated with significant benefits. You have here a doubling of PFS, you have a significant increase in median OS, and all of that with the same side effect profile that we saw earlier. A little bit of thrombocytopenia, a little bit of anemia, a little bit of transaminitis, but more than that, not a major issue in terms of what one gets. So the conclusion from these trials is that Kadcyla became also the standard of care if you were in metastatic and you hadn't used it yet for any patient with more than 2 lines of therapy compared to other chemotherapies. The improvement in the OS was certainly significant. And the other important thing here is that what happened at this point is HER2 became validated as a target even after multiple lines of therapy, and even after the HER2 target has been targeted in previous lines of therapy. What about kinase inhibitors? Okay, HER2 kinase inhibitors. So lapatinib was the first one that we became introduced to. It acted intracellularly by blocking signaling through HER1, HER2 heterodimers, homodimers, and heterodimers. Okay, it was labeled as a much more potent inhibitor of signaling than trastuzumab. And I remember when GSK started promoting lapatinib, we were all very excited. We were very excited because we were all told it was 10 times more effective than trastuzumab. So we were all very excited when this small molecule became introduced. Okay, it also induced HER2 receptor accumulation, and the combination seemed to work synergistically. So the EGF trial showed a randomization in breast cancer of lapatinib versus lapatinib plus capecitabine versus capecitabine. This is the trial that established this in patients who had prior trastuzumab in the metastatic setting. And you can see here that it was quite clearly demonstrated that there was definitely benefit to continue targeting of the HER2 genome, and more importantly, that this combination, when given together, lapatinib capecitabine, did better than capecitabine on its own. Okay, so now everybody didn't know. Okay, so where does lapatinib fit relative to trastuzumab? Is it the same? And the NCIC CTG trial showed us clearly that when you compare the two of them head to head, the taxane plus trastuzumab did better than the lapatinib plus taxane. Okay, so then we would know that actually, if we compare the both two together in the first-line setting, the trastuzumab-based combination would always take pride of place. And so the second data set was a cerebral trial, investigator assessed PFS, lapatinib capecitabine versus trastuzumab capecitabine, and you can see that in the OS scenario, the trastuzumab capecitabine performed a little bit better than the lapatinib capecitabine. So the combination now was something we needed to investigate, okay? Because when you look at the two of them together, the lapatinib induces accumulation of HER2 receptors, while the trastuzumab induces HER2 depletion. So because it activates ADC, we've had animal models that showed that the two of them together significantly dropped the ADC accumulation. And then, therefore, the rationale for the combination in HER2-positive breast cancer patients that were resistant to trastuzumab became established. And so the trial was done where lapatinib was compared to lapatinib plus trastuzumab in the metastatic breast cancer scenario. And you can see here that, please bear in mind that the majority of these patients received therapy in 5th plus line of therapy. And there was about 20% of patients that had brain metastases. So despite the two of these things, despite many patients having had 4 lines of therapy and then only getting to receiving combination treatment, we find that there is roughly a 12 months survival difference, a 12-month survival benefit with the combination versus lapatinib single agent in patients on metastatic breast cancer. So important to know that this is also demonstrated despite the fact that patients had crossed over during these trials. Okay, so the first HER TKI became established in the therapeutic armamentarium of HER2-positive disease in the metastatic setting. Tucatinib was the second drug that became available, possibly the third drug. However, we'll discuss tucatinib now. It's orally active. It induces reversible and selective HER2 inhibition, highly selective for TKI with HER2, without significant inhibition of EGFR, because we were able to establish with the lapatinib that the EGFR inhibition gave us all the skin problems. And actually, the skin problems didn't add to the ability to the HER2 effect. It just gave us a lot of rash. It also was less diarrhea causing than the other agents, and it was smaller than lapatinib and neratinib. So therefore, there was a huge potential, particularly for brain metastases. Enter the third line, enter the HER2 CLIMB study, tucatinib trastuzumab with capecitabine, previously treated HER2-positive metastatic breast cancers. They were head-to-head, comparing the triplet combination with trastuzumab capecitabine. Okay, patients had prior trastuzumab, prior pertuzumab, and prior TDM1. And interestingly, brain metastases were allowed in these patients. You can see from the primary endpoint, which is PFS, that the triplet combination tucatinib plus trastuzumab capecitabine gave you a 46% risk reduction in terms of disease progression. So that's pretty good for this poor group of patients. And the survival was borne out as a 34% reduction in risk of death. So we can see here this particularly poor group of patients do still benefit from this triplet combination. Again, the adverse events, the adverse events are in keeping with having a TKI plus capecitabine. So diarrhea is a problem, PPE is a problem, nausea, fatigue, vomiting can be a problem, stomatitis can be a problem. Again, these problems are manageable, but you need to recognize it. So the conclusion from the HER2 CLIMB is that tucatinib plus trastuzumab and capecitabine is an active combination in heavily pretreated patients. Gives you a significant benefit in OS, 34% reduction in risk of death, and a 46% reduction in risk of disease progression, despite having been pre-treated with monoclonal antibodies. Unfortunately, despite all of these therapies, many of our patients experience resistance to targeted therapies. There are several HER2 targeted therapies for treating HER2-positive breast cancer, and there are several mechanisms of resistance that have been reported. There's upregulation of HER3, the shift in dependence of signaling in PI3 kinase, there's alteration of trafficking export proteins, and there's downregulation of HER2. And I think this kind of sets a scene for where we're going to go hereafter in terms of what other agents are available. To end with, I'd just like to show you the treatment algorithms that one had at this point. So in first-line metastatic disease, we'd give people at that point chemotherapy, and we give them chemotherapy with dual targeted therapy. Okay? If the patient progressed on that, then they got TDM1. Okay? If they progressed on the TDM1, then you had a combination of either the HER2 climb strategy, which was tucatinib, trastuzumab, capecitabine, or one of the other agents in terms of clinical trial. Okay? And then if they progressed on that, then they for palliative treatment and palliative chemotherapy for the most part. And that's how we managed patients in this field at that point. So that was the current landscape, and this was the landscape at that point proposed by Javier Cortez. First line, second line, and third line. And I believe that this adequately sets the stage for what is to be now the data presented on the trastuzumab deruxtecan. Thank you for your attention.
Thank you very much, Professor Moodley. That was an excellent presentation, giving us the chronology of, what the last 2 decades have shown us as far as HER2 blockade is concerned. That has, just the outline of the trials, the evidence, and that has advised the guidelines. So I'm also privileged to invite our second speaker, and this is none other than our very own Dr. Njoki Njiraine, who has trained extensively in South Africa. She's a consultant clinical oncologist at the Kenyatta National Hospital and practices privately in many private hospitals. She holds a master's degree in radiation oncology from the University of Cape Town. So Njoki this evening is going to take us through what we call the story of NHER2. Thank you, Njoki.
Thank you, Dr. Carrier, for the kind introduction. Sure. And my Perfect. So my work is to walk you through the story of NHER2 from development and what the drug does. I need to tell you that these slides are for educational purposes. Do not replace your professional judgment in making decisions. And Astra is not responsible for how you use this information to treat your patients. But I'm excited that we have this drug. So my outline is basically to go through the antibody drug conjugates. What are they? Why is TDXD a unique ADC? And I'll use that word because it's a mouthful to keep saying antibody drug conjugates. The overview of the Destiny clinical program, which is basically all the studies that have been done with TDXD, and the proof of concept, which is the Destiny Breast 01 and Destiny Breast 02. So what are ADCs? ADCs are basically drugs that basically you have a monoclonal antibody at the top, you have a connector between the two, and a payload, which is basically something that is tagged onto the molecule to deliver chemotherapy. The beauty of this is that we know our target, which is HER2. We are then going to give this monoclonal antibody that will bind to HER2 and that complex is internalized. And that has been the principle of using ADCs, whether in breast or you're using it in any other setting. However, we know we need to harness the beauty of putting our specific target to deliver chemotherapy to that particular area. These linkers that are usually there between the drug, in the older drugs would actually have to be internalized into the cell before you get any effect around where the tumor is. The newer molecules are able to give you something called the bystander effect, which is basically to be released even outside the cell to give even more effectiveness around where the tumor is sitting. Now, ADCs were basically developed because traditional chemotherapy had no way of distinguishing which is the target cell versus the other normal cells, and this is the beauty of it. Number two, chemotherapy, for the pharmacist in the room, will have two things that we are looking for. What's the maximum effective dose and what's the maximum tolerated dose, and that basically gives you your therapeutic index. So I think the beauty of developing these drugs was to expand that therapeutic index such that you can give a small amount of drug but get the maximum effect for that. And again, because chemotherapy was lacking tumor-specific effect, so the ADCs were to overcome that. Now we then know the previous ADCs that had been developed had an uncleavable linker, which basically meant that the whole complex had to be internalized into the cell before that linker breaks off. And that now has been the development in terms of making a linker that can easily disintegrate. And as I said, in terms of the bystander killing effect, it is literally if you're next to the chemotherapy drug, the cell gets killed. So you actually get more effectiveness of the drugs. The new generation ADCs are good at this, and they have a bigger bystander effect. So what do we want the newer ADCs to have? Very specific selectivity for the antigen. So if you're binding to HER2, bind and bind well. Then the payload, we have improved the payload of the chemotherapy such that you have high drug potency. We want a short half-life of the payload, and we have high and homogeneous drug antibody ratio. And I think that's the beauty of it. You have less antibody but carrying a big load of medication. Then the linker needs to be stable, and it is tumor selective. So what does TDXD do? It has 7 attributes that we'll go through. And basically it's a humanized HER2, IgG1, monoclonal antibody, again a mouthful, but that basically tells you how it works and what it binds to. The payload is a topoisomerase 1 inhibitor, and the linker is a tetrapeptide-based cleavage linker. The pharmacists tell me this is exciting to know all those terms. For me as an oncologist, does my patient have expression of HER2? Can I give the drug? Now, the number one is that the payload mechanism of action is that now the payload is basically topoisomerase 1 inhibitor, which is irinotecan, and conjugated to the trastuzumab. Then the potency of the payload is 10 times higher effectiveness of the active metabolite irinotecan. The other thing is that you have a high drug antibody ratio, basically maximizing that therapeutic window that we talked about. So because of the high effectiveness, that DAR is pushed all the way to 7.7, which means you are allowing more drug around where the tumor is sitting. The other thing is that the linker is stable within systemic circulation. So in essence, it will limit the systemic toxicity that you will get from the drug because the drug is firmly attached on the monoclonal antibody and the payload. Again, this improves to make sure that the stability of your drug for TDXD, if you look between TDXD and the total antibody that you get, you basically have the drug is attached quite securely. The other thing is that you have a tumor selective linker, which basically once you attach to the drug, that is only when the linker basically gets cleaved, and then the drug is actually released in the vicinity of where the tumor is. The other thing is because we said HER2 is extracellular, we want our drug delivered intracellularly, we have high membrane permeability, and that's important so that you can get concentration of the same drug in your HER2 positive disease, and that again has been shown in terms of where the control is, and of course your tumor response is based on how much you can get. Okay, so the Destiny Clinical Program, and basically this slide is to show you where we have all the trials. Okay, I will just go through. There is the top, which is HER2. As long as you're HER2 positive, we will give you medication, and there are many trials that are there from early disease, advanced disease, in second line and in third line. There are also patients who are hormone receptor positive and HER2 negative, so which is now the new class. I'm sure Prof. Shaheen will talk about the HER2 low class, where now we have data from Destiny Breast 06 and 04. And in that category for patients who before we were not sure whether we need to give them HER2-directed therapy. And even in triple-negative breast cancer. So I think TDXD is going to be widely used across the spectrum for breast cancer. Now, the Destiny trials that are there, and I will, as you know, for drug development, we always start with a new drug in the heavily pretreated metastatic setting. When we have proof of concept, then we move to your phase 3s in patients with locally advanced or heavily pretreated metastatic disease, then moving to early disease. So the initial trials that were done was the first one, which was Destiny Breast 01. And as you know from development of clinical trials, this was a phase 2 study design. It was basically to establish what are the pharmacokinetics, what is the dose that we need to give patients, and how do we continue with them. If you see patients who are basically unresectable or metastatic, they were in good performance status, which sometimes are not our typical patients that we treated. We allowed brain metastasis to be there, and we excluded patients who had interstitial lung disease, which is one of the side effects that we are most worried about with TDXD. The primary endpoint was the objective response rate as assessed by RESIST, and the secondary endpoints of investigator-assessed overall response rate, duration of response, the PFS, the OFS, the pharmacokinetics, and safety. And this was in 2019. And the first phase of the study was basically 3 dose levels, 5.4, 6.4, and 7.4. Then they enrolled in terms of the dose finding, which was 5.4 versus 6.4, and maintained the patient on the standard dose that we know, which is 5.4 milligrams per kilo. In terms of the patient distribution, 100% of them were female. Majority of the patients, of course, were from North America or Asia, good performance status, and about 52% of them had hormone receptor positive. But what I want to highlight is the characteristic of how many lines of treatment they had had. Heavily pretreated patients. 91.8% of them had visceral disease, and about 13% had brain metastasis. And again, this was brilliant, and I'll show you the curves, because an objective response rate of about 60, that is impressive. In patients who have received multiple lines of treatment, who in the end we would not be giving them anything. And in terms of duration of response, the 6-month response rate, it was also quite impressive. But in terms of plotting each individual patient, I think, you know, in oncology, when we see such curves, we're like, now this must be a magic drug, because how does majority of the patients have response in terms of even some having complete response? And that was impressive. We have not seen this, especially in the space of heavily pretreated HER2 positive disease. If you look at this in terms of the objective response, in terms of the stratification for the patients, there was benefit across board in terms of all the stratifications that we looked at. The median PFS was 16.4 months. Again, in patients with brain metastasis, it was 18.1 months. So that tells you, and when we think of HER2, we always think the brain as a sanctuary site. Will the drug actually be able to penetrate into the brain? And this actually proved that TDXD will still be able to control the disease. The overall survival is as shown, a median follow-up of 11 months, and that has not been reached, was not reached on Destiny 01. But the safety profile is that we have to be aware of the side effects for the patients. Interestingly, the patients who actually discontinued were about 28%, and drug-related was about 27%. And in terms of death, only 9% of the patients. In terms of side effect, the main one usually is tiredness. You get issues with nausea. What we are most worried about is ILD, but we will talk about that. And you can see how many of them had any grade, but what we are most worried about, grade 3 and 4, it was actually quite well tolerated by the patients. But there are some adverse effects of special interest, which is the ILD, which we are most worried about. And this is where we start to think about the drug antibody conjugates in terms of the mechanism of action and what inflammatory response they actually mount within the normal tissues. And ILD is what we worry about. And note that about 25% of the patients had ILD, but in terms of the grade, we still had a significant part, which is now what we most worry about in terms of side effects for the patient. So the conclusions of Destiny Breast 01 is patients who are heavily pretreated, we have a drug that patients can access. The objective response rate of 60% was consistent across all the subgroups, and again, safety was consistent with what had been seen in the phase 1 study, and of course, ILD being the one that was identified, we need to ensure that we are monitoring for symptoms, and if we suspect ILD, stop your TDXD, start your steroids, image your patient, and according to the protocol that you have. Just to point out, the previous trials that had been done, like in TDM1 for Emilia, TDXD, which I think Dr. Manel is going to talk about, Breastini 03, basically had established TDM1 as a standard of care in second line. But based on the newer studies, we are now seeing TDXD has moved up more than that. The TDXD Breastini 01 was in third line. So that also demonstrated that even in patients who are heavily pretreated, you can actually be able to get benefit from that. Destiny Breast 02 was now the other study after phase 2, which basically again looked at patients who had unresectable or metastatic disease, who had had radiographic progression and had been treated with TDM1 before. And we stratified the patients according to hormone receptor status, you had had prior pertuzumab or visceral disease. And the investigator arm was TDXD at the dose that had been established, and your treating physician choice. And according to the data that we now had, we knew that you can use trastuzumab with capecitabine or lapatinib and capecitabine. And then we looked at PFS and overall survival. Now, this is where it gets even more interesting. So if you look at how many prior lines that the patients had received, the number keeps getting bigger and bigger as you go down the line. So you find that majority of the patients had at least 3 lines of treatment. Again, heavily pretreated patients. In terms of the median number of previous lines of treatment, it was 2. And if you look at what drug they had received before, it would be the biggest, all the armamentarium of drugs that we have in our market at the moment. But the progression-free survival, if you look at the curves, I don't need to convince you about the same. 17.8 versus 6.9 months with a hazard ratio of 0.35 and a very significant p-value. So again, patients who are benefiting from getting TDXD and as monotherapy, not in combination with chemotherapy. The secondary endpoint was overall survival, 39.2 versus 26.5 months with a hazard ratio of 0.65 with a p-value of 0.021. Again, the secondary exploratory points, which is basically if you look at the waterfall plot, same thing for the patients in terms of response and confirmed by blinded independent central review. Because that's something that I think in trials you have to think about. If I am the treating physician and my patient is on my trial, I may want to continue on treatment because I know the patient, I know the benefit that they're getting. But if somebody is blinded and we actually look at the response, then that is even more objective in terms of assessing whether the patients have responded. And that was clear between TDXD and the choice of treatment. In terms of safety, again the same, it mirrored what we had seen before, but of course because this is an ADC versus non-ADC treatment, the side effects of course were a little higher. But the side effects that we saw most, nausea being one of them, and for TDXD that were greater than grade 3 is the dark blue that you can see. Basically, the proportion in terms of how many had less than grade 3 versus grade 3, meaning the treatment was actually very well tolerated by the patients. So, Destiny Breast 02 basically confirmed statistically significant and meaningful improvement in both PFS and overall survival, and in patients who had had TDM1 before. And it also reduced the risk of progression or death. At the same time, the safety profile was consistent with what we had seen, and no new signals were actually elicited out of this trial. So basically, it shows that TDXD confirms that benefit versus risk profile in patients who have advanced HER2 disease. But I thought of putting this here. So it's like we're trying to compare oranges and, I don't know, oranges and another fruit. Because the mechanism of action, we've seen the improvements of how the TDXD is actually made, and in terms of what payload we are giving, but the drug-antibody ratio is important because how much drug can you deliver to where the target is, and that, I think, has been shown. We also have a tumor-selective cleavable linker for TDXD, and again, the issue of the bystander effect, which is important in terms of maybe improving the response that patients will get. So in conclusion, we have know that the role of TDXD in M1 disease is very clear. We have to be very aware of the side effect profile and again assess your patient because of the side effect profile that you're most worried about. And I thought the clinical benefit of the drug outweighs the cost, and I should have put the costs in quote because it's not about the finances, it's also about the side effects that the patient has, and in patients who before had no other line of treatment. Of course, the role has now expanded out of the M1 setting. We are now looking at things like HER2-low disease, locally advanced disease, and most probably in early disease with the other studies for Destiny. So thank you very much.
Thank you very much, Njoki. I think everybody sort of agrees that that was an excellent presentation. Payload, linker, cleavable, permeability. I think that was excellent and actually understood. And I think it will be very easy to make a case for what we call the bystander effect and the inclusion of what we call low HER2 and ultra low. I also have the great honor this evening of, having talked about the past, we've talked about the present, and now we want to see what we call a great translation of a bench or laboratory to bedside in this trastuzumab story. And therefore, I have the great honor of inviting Dr. Manel Mansour. Manel is a consultant medical oncologist and the section head of medical oncology at Aga Khan University Hospital, Nairobi. And she's also the current fellowship program director in the Department of Hematology Oncology. And we are all very jealous that they are able to run some clinical trials in HER2 therapies. Welcome, Manel, and thank you. She's going to talk to us about the paradigm shift in the management of HER2 metastatic breast cancer. Thank you.
Thank you so much, Dr. Chiari. So as the previous presenters were given their talk, I had an idea. So basically almost similar to Dr. Chiari's idea. As if we are one family of HER2. So Dr. Sean, if we had to have characters in this family, Dr. Sean would be the grandfather. It's not about age, don't get me wrong, but he's the pillar of wisdom. And today we are celebrating 20 years of trastuzumab. So he set the floor. Njoki would be the parent who prepares and paves the path for the generation. Wait till the end. I'm the firstborn who thinks I got it all, and I'm the smartest in the family, until the second and the third born comes on board. So, those Gen Z, Prof. Shaheen, you're wearing the hat of the Gen Z today. So I'll move to our presentation today. My role is to present Destiny Breast 3, TATU, which was a paradigm shift in the management of metastatic breast cancer, HER2 positive. So those are my disclosures. So you need to know that when a HER2-enriched breast cancer shows up in the clinic, half of them would be already at the metastatic stage. So that's why it's really important for us to tailor our treatment and then give our patients the best options. So, and as you have already seen in the previous presentations, there are milestones achieved in the last 2 centuries when it comes to the treatment options, which made actually the prognostic status change from poor or worse to actually favorable. But we still remain with one major issue for the HER2 positive breast cancer patients, which is the brain metastasis. So from the natural history of the HER2 positive breast cancers, the brain metastasis rate increases by 13% every year. But still, in view of the options that we do have, they are relatively favorable compared to other type of. So fewer metastatic breast cancer patients will actually benefit from the first-line treatment, but then as we are moving in the lines, there will be fewer and fewer patients benefiting from the next line of treatment. So for example, in the second line, 22% of the patients will not have the chance to reach the second line, and another 35% from those who benefited from the second line will also not have the chance to benefit from the third line of treatment. So that makes approximately half of the patient will not be able to reach the third line of treatment. And then also in terms of efficacy, the efficacy decreases with each subsequent line of HER2-based therapy. As you saw from the previous presenters, the PFS in the first line with the dual blockade plus chemotherapy is around 18.7 months, when in the second line, when we are using TDM1, it reduces to 9.6 months. Now the same TDM1 that has been tried on the third line gives you even a lower PFS of 6.2 months, based on the data that was shared earlier. So when you think of choosing the lines, we have to really choose wisely so that our patients get the most of all those options that we have available nowadays. And here I will talk about trastuzumab deruxtecan compared to trastuzumab emtansine in the BREST-3 trial in the second line setting of metastatic HER2-enriched breast cancer. So Dr. Njoki has introduced the molecule, and then just the key highlights why the study has been established. The idea behind the study is that we know that this newer ADC has a higher drug to antibody ratio, 8, versus Kadcyla, which is 3.5, but then also a tumor-selective cleavable linker, and then also a higher potency of the payload. And Dr. Njoki has explained it perfectly in details. So coming to the study design, so Destiny-3 Breast has enrolled approximately 524 patients who were metastatic HER2-enriched breast cancers, previously treated with chemotherapy and trastuzumab in the first-line setting. So those patients were randomized into 2 different arms. The standard of care at that time, which was TDM1 versus trastuzumab deruxtecan. The primary endpoint was the progression-free survival. The key secondary endpoint, the overall survival. And the secondary endpoints, the objective response rate, duration of response, and the safety. The stratification factors were based on the hormonal receptor status, prior treatment with pertuzumab, yes or no, and the history of visceral disease. The pre-specified overall survival interim analysis was planned with 153 events. At the time of the data cutoff, which was July 2022, 169 overall survival events were observed, and the p-value was statistically significant. So at the time of the data analysis, the patient's disposition, and this was in San Antonio 2022, the patient's disposition at that time was as shown on this table, and the key message is that at the time of data analysis, 70% of the patients from TDXD had treatment discontinuation versus 93% in the TDM1 arm. And the reasons for this discontinuation of the treatment was almost 70% because of disease progression in the TDM1 arm versus 36% in the TDXD. And in terms of adverse events, it was, on the other hand, higher from the TDXD arm at around 21% versus 8% in TDM1. When you look at the baseline characteristics of the patient, they were perfectly identical on both arms, which would allow the statistical significance of the study findings. And then if you look at, and the patients that were allowed in the trial have received either 1, 2, or 3, 4, or more lines, but the majority have only received 1 line in the metastatic setting. So coming to the endpoints of the study, the first and the primary endpoint of this study was to improve the PFS, which is, when you look at these curves, it's basically self-explanatory. As you can see, in the TDXD arm, there was a median PFS of 28.8 versus 6.8 in the TDM1 arm. So that is 4 times longer for in HER2 compared to the comparator arm. And the hazard ratio was of 0.33, which is really enormous in the metastatic setting to have such a difference and such an improvement of the PFS in the metastatic setting. And when you look at the subgroup analysis, actually the benefit is consistent in all the different subgroup of patients. So regardless of the hormone receptor status, the patient, if received the dual blockade, trastuzumab, pertuzumab, or just Herceptin, the patients who had visceral disease, and then based also on the different number of lines of treatment, the benefit was still there. Even the patients who were allowed with stable brain metastasis, they still benefited from Enhertu. The key secondary endpoint of this trial was the overall survival. So it is not yet reached, but as you can see, the experimental arm, the one with Enhertu, is showing significant improvement in terms of the overall survival compared to the arm that has received the standard of care at that time, with a hazard ratio of 0.64. Same thing, when you look at the subgroup analysis, based on the stratification identified initially on the trial, all the subgroups have benefited from Enhertu compared to the TDM1 arm. The other secondary endpoints of this trial was the objective response rate. And as you can see, 4 out of 5 of the patients demonstrated a response, and 1 out of 5 would achieve a complete response. So basically, the objective response rate is around 79% for the Enhertu arm, with a 21% of complete response. While when you look at the TDM1 arm at that time, 35% of objective response rate, and only 10% would achieve a complete response rate. Basically, this also reflects into a longer and a more durable duration of response. As you can see on the last line of this table, in the Enhertu arm, the median duration of response was 36.6 months versus 23.8 months. And here, a PET scan of one of our patients who was treated with Enhertu. Obviously, at that time, we didn't have the new change in the guidelines. So this was, I think the patient was treated in 2021. And at that time, Enhertu was not in the second line setting. And even if it was, I don't think anyone could have afforded at that time. So she received several lines of treatment. And she obviously had a much heavier disease than the one on the left side. But by the time she progressed on TDM1, we had that disease burden, and then we started her on Enhertu. She managed to achieve almost a near complete response, and she was stable for a full year of Enhertu. In terms of side effects, Njuki has already explained the possible side effects from this ADC. And basically, it is reflecting what is the trial in our practice. It's reflecting what the trial is showing. So anemia can be really a significant, and the hematotoxicity can be really a significant side effect, especially the neutropenia. The nausea is something that sometimes can persist the whole of the 3 weeks. Neutropenia, what I have mentioned, the alopecia actually, especially when Enhertu comes after Kadcyla, sometimes the patients get upset by having the hair loss again after a period of time where they kept their hair during the maintenance period of the dual blockade pertuzumab, trastuzumab, and during the TDM1 phase. But most of those side effects are usually manageable. We can follow the guidelines in terms of the dose reduction, in terms of the supportive treatment, and we are able to provide a better quality of life for the patient while getting the benefit of this treatment. ILD was really something we were fearing in our department. I remember when we started using Enhertu, we were so scared from having patients who could develop an ILD. But what we did is to really emphasize the symptoms, educate our patients, make sure that we are reachable in case of any respiratory symptoms. But I think, Sidna, we might have treated about 15 patients in the department with HER2. I don't think we've seen any patient having any ILD from our experience. And as you can see, majority of the reported ILD in the trial is grade 3 or less. So life-threatening ILD was not really, it was 0, grade 4, grade 5. But what we have noticed is that with longer treatment exposure to HER2, and a longer follow-up, ILD pneumonitis rate increased from 10.5% to 15.2%. So it's something that we clearly need to watch out for. But just to let you know that in our very shy experience with HER2, we didn't really have any significant side effect. So this slide is summarizing basically what we have mentioned in terms of the toxicity profile. As you can see, the blue ones on the left side are the higher grade of toxicity, and it wasn't that significant. And then if you look at the treatment-related drug discontinuation, basically there was 14.8% in the TDXD arm versus 7%. So just to summarize a bit the results from the Destiny Breast 3 trial. So as you can see, the PFS, or the efficacy of the drug on the very first slide, used to reduce from line to line. Here it's something that has completely changed the landscape. PFS of 28.8 months. And then if you remember also the slides that Njoki has shown, when it was used in later lines of treatment, the PFS was 19%, and then there was another study 9%. So basically, the efficacy of the drug can reduce if you're using later the drugs. So that's why in terms of choosing wise the studies, and we are really happy to have the drug nowadays, at least as an option. We used to only use it as a special order for the patients once we exhaust all the options that are available in the country. So maybe we should follow the guidelines now that the drug is available. And then I'm not sure if AstraZeneca might have a program, an access program, so that we can, maybe I'm just spoiling a surprise at the end, I don't know. So if we can have an access program for our patients, for example, we will have more patients who will benefit from this completely landscape changing and life game changer. So just to wrap up, anti-HER2 targeting agent should be your main backbone treatment for the HER2 enriched breast cancer patients throughout the metastatic lines of treatment. And then using wise the treatment options so that all in all, you can have a cumulative longer progression-free survival for the patients, but then also a good quality of life. And TDX has really shown promising results even for the patients with metastatic brain disease, if they are clinically stable. So that's what led to the change of the standard of care, and then HER2 has been placed as a standard of care in the second line setting in the NCCN guidelines, so based on the ASCO guidelines, and then also for the ESMO guidelines. So this is how the guidelines looks like now. Maybe until the Gen Z comes in on board and then change it, even in the first line or in the second line setting. And I'm just a reminder, kindly, for the first line setting, we have a clinical trial running in KNH for the HER2 positive breast cancer. You can get more information from Sitna and Joki at the end of the meeting, but also be updated about the opportunities that are available in the country. So now we have HER2, which is really a big achievement, but then also there are some clinical trials that might be interesting for a selected category of patients. And then this is a photo from the standing ovation of the Destiny Breast 3. It was really a very important day that has clearly changed the life of many patients with HER2 positive breast cancer. Thank you everyone for your attention.
Thank you very much, Manel. You didn't disappoint. Now I'll call all the ladies to come and to the stage with me. I hope Professor Modley is still online so that he can also, answer the questions. Now, Manel, you promised to be the firstborn. I was hoping that you're going to talk about pocket toxicity, but I see you've been very diplomatic. and you've not discussed that. So we are going to have a question and answer session that will run for about 10 to 15 minutes. We are running about an hour behind schedule, but that doesn't mean that we don't use this excellent opportunity to learn. And, you know, probably, you know, being the very, very firstborn, I don't know what I'm, the parent.
So we have the
No, I'll probably ask Professor Mudli to comment about the African representation in the trials that have been excellently outlined this evening, as I also welcome other questions to some of the speakers this evening. So I think we can raise our hands. Professor Mudli, you've heard our question?
Can you hear me? I hope you can.
Yes, we can.
Yeah, look, there's been, I mean, recruitment for all of these trials, the Destiny ones. We've had active centers throughout the continent, and certainly there've been recruitments, different centers. There've been a few in Johannesburg as well that's recruited for these trials. So providing there is an adequate trial center, I think all these multinational companies all regularly have clinical trials available. And to that end, I think we are all participant in the process. Obviously, just purely based on sheer numbers, we don't often have what it takes, you know, to shift the needle. But there's still a lot of patients, and a lot of patients benefit from these therapies because of clinical trials. Indeed, where we work, and it's probably true for you too, many of these patients, the only way they can get access to these novel therapies is on clinical trials. Because for the rank and file normal South African, many of these drugs are way out of their reach, even with those with insurance. So we often have that problem. So from that perspective, we often use clinical trials ostensibly as a mechanism of getting drug.
Thank you, Professor. Thank you. On this end, I'll welcome questions from the floor to our esteemed speakers this evening. Thank you, Peter. Yes? Peter is a medical oncologist working in Kenyatta National Hospital, also running the Nakuru Clinic. Yes, Peter. Peter, just speak. I think we shall hear you. Yes.
Yeah, thank you for that. And I think the slide I showed in terms of the Destiny clinical program, there are other studies like Destiny 015, which I think is actually in the triple negative cohort of patients for the HER2 low or HER2 1+, which traditionally we would not give any HER2 treatment. And I think the bystander effect to radiation oncologist is not a new concept, because we get that once you deliver radiotherapy and the cells that are around where the initial tumor would get affected, but it's actually because you're increasing the immunogenicity of the tumor and improving your immune system from being able to see where the tumor cells are. So I expect that TDXD will continue like surpassing all the expectations we have in terms of the traditional, what we thought was HER2 positive disease. And remember, HER2 is a normal molecule. It is overexpressed in breast cancer patients. So technically you can use it in any area. Yeah, thank you.
And hence, Joki also they use in other solid tumors. Peter, are you satisfied? All right. Very good. Any other question? Yes. Daktari, let me not be big boss. You tell us your name and where you work, just very shortly.
We saw that trials between TPA1 and TPX, we saw that TPX so that gives us a difference between TPA1. As it literally follow the architect or what's its future. And the second question is that we've seen that TPX can work both in too rich and too low. Is there any trial or any data which we have which shows that if it works in a too rich and a too low? We say that in a too low it works much less, and in a too rich it works.
Thank you, Riaz. Very, very good questions. I think the questions were to Njoki and I think to Manel. Yeah.
So the first question about where is the place, where can we place now Kadcyla or TDM1 in this setting? So for the Destiny Breast 3 trial, those who failed in HER2 at some point, they received as a third line Kadcyla, and they were still benefited from Kadcyla. Obviously, they will not get the same objective response rate, but it still has a role in the third line setting. And furthermore, recently there was a study that was published recently that you can still bring back the dual blockade, but you change the chemo backbone, and they will still benefit in the third, fourth line of treatment. So the other molecules will still have a place. It's just how and when to place them. And obviously, in HER2, like Dr. Carey said, the cost is really prohibitive. I don't think 100% of our patients will ever access the drug, unless, and this is a call for AstraZeneca, I know there are so many, we can have the access program #1 for the proven indications, but then there are so many other running clinical trials, Destiny in the neoadjuvant, Destiny in the adjuvant, in the first line setting. I think it would be important for once not to see our patients represented in the last line, other ethnicities down there. So maybe if we can have our own data, yeah, it would be really interesting, and it would be really, I mean, a big opportunity for our patients to access that, the drug, yeah.
So Riaz, I think well answered. And you've understood that sometimes it can be reused, and that mechanism algorithm she showed us can be exchanged. Yeah, just pocket toxicity. It's interesting, Manel, you know, Africans are represented as others. It's either we can afford the drug and we participate and have high numbers to be represented, or basically to expand what they call, you know, these programs, what do they call them? The ones that, you know, the drug company will give us a big discount, patient access, and therefore more of our patients can get involved, or we basically get involved in clinical trials like Aga Khan and Kenyatta are doing. So a big challenge to us. Njoki, are you surprised that such a big molecule can cross the blood-brain barrier?
Of course. In my traditional thinking, it was we either give radiotherapy to make the blood-brain barrier permeable. So when we looked at the data, like the initial trials where the patients were metastatic, it was amazing. But what I think, in my simplistic thinking, if you're mounting an immune response because of the bystander effect, you most probably are ramping up your own immune system to actually work even in the blood-brain barrier without the actual molecule getting into the brain. That might be one of the reasons why we saw response, because it was for the first time in HER2 disease where once you get brain mets, then we were thinking we give you radiotherapy followed by radiotherapy, and then that would only improve the penetrance of the molecule into the brain. And I think maybe it's challenging all that we have understood about HER2-driven disease before.
Thank you. Thank you, Jesse. You'll quickly introduce yourself.
Thank you very much for
The Gen Z will answer your question.
But just in the trials, you saw about HER2 1+, and the 2+ that was, that we do fish for were represented, but I think it's true. Professor Shaheen will give us a very clear answer. Thank you. Now, before we take another question, dear Helena, there is Dr. Kiambi, who is a clinical pharmacist in Kenyatta, saying that was an excellent presentation, given the side effects encountered with ENHER2, e.g. nausea and vomiting, some of which are grade 3. Would you recommend a standard antiemetic protocol as pre-medication?
So initially, for the first cycle, we start with the mild to low emetogenic protocols, and then if the nausea persists, and then we had to even use fosaprepitant for some of the patients on ENHER2. So we just escalate as per the patient's need, but majority, we just use for mild and low emetogenic chemos. Yeah.
And it helps.
It helps, yeah, it helps. Yeah.
Very good. Thank you, Manel. Helena? I'll bully Helena a little bit. She's the past president of Kesho, but she'll also tell us where she's found. So Helena, where are you found? All right, Dr. Helena Musau, thank you.
So the majority of the side effects that we encountered with the patients on ENHER2 are fatigue, significant fatigue, nausea. So especially when we started using it initially, we were really expecting it to be as smooth as TDM1. No, nausea was really a concern. Neutropenia, and we had to reduce the dose because of the neutropenia. ILD, we've never seen any patient, and I think roughly we've treated 15, maybe I would say. We didn't see any ILD. There was one patient, metastatic gastric cancer, HER2 positive, where we suspected ILD, but then it was like lymphangitis from his disease. It wasn't from the drug. Did I forget? Alopecia really annoys our patient. Bone marrow suppression, nothing really significant. Like thrombocytopenia, we didn't see, unlike the TDM1. Yeah, anemia, we didn't transfuse any patient on ENHER2, no. I mean, it's there, but it's manageable, yeah.
Thank you, Manel. So like Helena has asked, do you have a system where they have routine, like the way we do routine echocardiograms? Do you also have routine, say, CT scanning or lung function tests to be able to pick?
May I interrupt you guys?
Remember, it's a big fear for everyone. It's a big surprise that it's not as as frequent as we expected, just like other drugs like osimertinib. So what do? You routinely do CT scans?
So we...
Excuse me?
Yes.
I'd just like to add that there is a lecture coming on side effects and side effect management of ENHER2 next, where most of these things will be discussed. It's on the program.
Oh, thank you.
That's the next talk.
Okay, thank you. We take note of that. So any other question from the floor? So we are having many other sessions where we are going to discuss ENHER2, other uses in lung cancer and the other solid tumors. I think we'll take a short break, and because we are running out of time, probably we'll just give you 15 minutes to take a snack and tea, and I think we were allowed to bring in our snacks as we begin the next session. So thank you, everybody, for your active participation.
You lied to me. No, wait, I got caught up.
You girls are nice.
Thank you, as are you.
So before Wednesday, we need a chit chat. nitanunua waini. We have no plan. You like all that, yeah. I just feel like I've been thrown in the deep end. And then we come for this other one. All right. Nitanunua waini. Thank you very much. Gosh, lazima tupige picha.
Mic check, mic check.
It's working now. So, welcome back, and sorry to rush you from the break, but we know that we are almost 1 hour behind the schedule, and we don't want to keep you anymore. So we are heading to the next session, and for this session, our chairperson and moderator is Dr. Sitna Mwanzi. Dr. Sitna is a consultant medical oncologist at Kenyatta National Hospital. She attained a specialist certificate in medical oncology from the Royal College of Physicians and Association of Cancer Physicians in the United Kingdom. She also has a Master of Science in Advanced Oncology from Ulm University in Germany. Dr. Sitna, the floor is yours. Thank you so much.
Thank you, Mohammed. Good evening, everyone. Hey, you've had some tea. Good evening, everyone. We have the right to withhold dinner. Yeah. So the next session is more about toxicity and also the HER2-low breast cancer, because we've had lots of questions about that with the first session. So a lot of your questions will be answered now. And to kick us off is our speaker who was here before, Dr. Mudli. He's already been introduced as a medical oncologist, and he'll be talking about a case from clinical bench to the clinic. And then we'll have Andrew, Dr. Andrew Owor. He's not an oncologist. You're probably the outlier in the room. But a very important aspect of our care. He's a pulmonologist working at Kenyatta National Hospital. You've heard us talking about interstitial lung disease, so he'll be giving us more perspectives about diagnosis and treatment. So Dr. Mudli, over to you.
Thank you very much. I hope you can hear me, and I hope my slides are projecting.
We can hear you.
IT?
Waiting
Okay.
a moment for your slides.
Are the slides up yet?
Not yet. Give us a minute.
Okay, when the IT gets around to doing it, we can chat.
Oh, okay. Dr. Mudli, I'm informed you should share from your side.
It says I am screen sharing. Okay, so let me try again.
Yes, we can see it now. Thank you.
Can you?
Yes.
Okay.
Yeah.
All right. So I'm going to tell you something about side effect management, particularly the common ones, and secondly, the more important ones, and how we manage it. And I will just finish off with a particular case that I've been seeing with HER2 positive disease that's on TDXD. Okay. This is the AstraZeneca disclaimer slide, which you've already heard and seen a few times. Okay, so as any treatment option, if you're going to make it last, you need to manage the adverse events. And in a nutshell, the adverse events that you get with TDXD are nausea and vomiting, alopecia and fatigue. There are some less common side effects, and then the most important thing to mention is interstitial lung disease / pneumonitis. And the reason they're a very important thing to mention is that it can be fatal. And although the incidence is very low, if you don't stop it when it happens, that's the end of being able to use the drug in these patients. So it's very important to be aware of. Okay, so let's tackle nausea and vomiting, as one of the guests today have asked about. Okay. Remember, you need to know what type of nausea it is. You get anticipatory. So these patients, they've learned or conditioned that whenever they either get a smell, a sound, a sight, a smell, or anything like that, they present with nausea or vomiting. The acute is that period of nausea and vomiting that occurs within the first 24 hours, and it's common with IV infusions or even oral administrations. The delayed occurs after 24 hours and may last a few days after treatment. Breakthrough nausea and vomiting is one that happens despite all the treatments you're giving them, and they require more than 3 or 4 agents to manage. And then the last thing is refractory. The refractory is the failure to control nausea and vomiting despite being on many agents. Okay, So what are the guidelines for the classes of antiemetics for patients having chemotherapy? Well, the first group of drugs are 5-HT receptor antagonists, and you've got a whole host of them now. The one I tend to use is palinositron because it has the longest half-life. Okay. Then the second group of drugs are NK1 receptor antagonists, and we have aprepitant, fosaprepitant where I am, and they are used orally. I don't tend to use them intravenously because the agents that we have available tends to cause a bit of a burn intravenously, and there's no reason why they can't use the oral agent. So that's great. And the commonest one we use is dexamethasone, is corticosteroid. Okay, and the corticosteroid here is for acute emesis and for delayed emesis, and we can use dexamethasone in all its different iterations. So what do we do when we give TDXT? Well, you give antiemetic prophylaxis before the drug. Okay, you give them if there's delayed emesis, then you give them therapy then. And if they have delayed, you need to delay your next dose until the side effects have resolved. Okay, and you only resume therapy once once the nausea, vomiting have resolved. Remember that if it takes less than a week, you can continue at the present dose regimen. But if it takes more than a week to resolve, then you cannot continue at the same dose. You have to do one dose level correction. In other words, drop the dose down by a level. Okay. So what's a real world experience in terms of management of nausea and vomiting? Well, the real world evidence is that usually they all must get antiemetics. If you don't give them antiemetics, they have a really bad time and you're not going to be able to give the drug. So that's the first thing. The second thing is that you always give them a 5-HT receptor antagonist, you give them all corticosteroid, and you give them an NK1 receptor antagonist. So that's what they get prior to the TDXT infusion. They then get the TDXT infusion, and then they get corticosteroid and or olanzapine or the 5-HT receptor antagonist, depending on whether you used a short-acting or a long-acting, okay, for the delayed prophylaxis. And if they have breakthrough nausea, vomiting, you need to look at the ancillary drugs mentioned there, steroids, olanzapine, prochloromazine, all these drugs purely to prevent or to try to manage the breakthrough nausea and vomiting. And this is very important to remember, because if this happens more than once, you're not going to be able to manage this patient and they're not going to be able to get repeat therapy. And remember, if you got breakthrough nausea and vomiting, then you're going to may have to delay the next treatment until this is better. There are other things you can advise patients. Okay, one of the things you can help with the nausea is you encourage them to have small meals. Simple things. Tell them to avoid foods that give them nausea. They must be upright for at least an hour after a meal. You don't eat food that's extremes in temperature that can cause nausea. You must follow medicine's directions, because sometimes some medications require you to eat pre-meals before you eat anything. Drink a lot of fluid, and by fluid I mean non-alcoholic beverages. Sometimes a dietitian or a specialist nutritionist can be of assistance. Practice meditation and relaxation techniques, and things like acupuncture help a lot in terms of management of nausea. Now, when you're vomiting, it is important to encourage them as to how to manage this. So lying on your side will help prevent inhalation of vomit. Frozen liquids like ice chips helps there. Once the vomiting stops, we need to give them fluids. So you start with teaspoonfuls of cooled liquids, okay? You can increase to a little bit more every 10-15 minutes until you're getting enough fluid into the patient. Drink plenty of water. And remember to call your healthcare professional if you have trouble in swallowing. Do not wait until you're unable to swallow completely. These are the kind of things we explain to patients. So this is then now what the recommendations are. Okay. As I said, there are things you tell the patients on what to do. Please get them to keep a diary, keep a record, how many times they have nausea and what causes it. Also, ask them to please come for treatment in using loose, comfortable clothing. And always sit for at least an hour after eating with your head up. Remember, there's first the things you tell the patients. Secondly, there's what treatment you give the patients. The 5-H3Ts, the NK1 antagonists, the corticosteroids, the olanzapine, antipsychotics, benzodiazepines, the cannabinoids, phenothiazines, atypical antipsychotics, all of them may help with nausea and vomiting up front. Remember, it's very important to prevent this from happening rather than trying to manage it after it happens. So it is very important that you need to understand when you're prescribing this drug, do this like you do chemotherapy. Remember, you are giving this patient chemotherapy. You're just packaging it with the monoclonal antibody. Ignore the monoclonal antibody in the management of nausea and vomiting for patients getting TDXT. Treat this like you would treat a highly emetrogenic agent. Please, it is the best way to ensure that you're going to get patients compliant and you're going to get them to come back for the next dose. Remember, you start at 5.4 milligrams per kilogram, okay, for breast. Your first dose reduction goes down to 4.4. Your next dose reduction goes to 3.2. If you have to dose reduce more than 3.2, you'll have to discontinue therapy. Okay, so understand that. Understand that if you got nausea and vomiting that resolves within a week, you will then resume at the same dose. If it takes longer, wait for it to resolve. Then when it resolves, you need to go down one dose level. Okay, and if there's grade 3 nausea and vomiting, you need to delay until it's resolved to grade 1. Okay, and with that you come to dose reductions. Okay, so this is what the NCCN recommends. And remember, it says here, treat this as a highly emetrogenic protocol. Okay, so that involves giving you olanzapine using a NK1 receptor antagonist, using a 5-H3T, and giving steroid. Okay, you can use these things in different options. You can use the 5-H3T and the olanzapine and the dexamethasone, and then send them home on olanzapine for day 2, day 3, day 4, or you can use an NK1, 5-H3, and dexamethasone. But whichever option you choose, make sure that the patient's adequately controlled. Okay. These are listed here are all the ways you can give an NK1 and all the different NK1s and all the different 5-H3Ts. Okay, I'm sure you have access to all of them where you are. I tend to use the palonosetron because of the length, the half-life of the combination. Okay, this is the guidelines for antimesis. These guidelines are again general principles. The drugs used, the olanzapine, lorazepam, cannabinoids, phenothiazines, 5-HTs, and corticosteroids. All of them, if it's controlled, if your combination controls the nausea and vomiting, you may continue. If it's uncontrolled, you need to escalate what you're doing, add more agents, and consider a higher level of antiemetic therapy for the next treatment cycle. Okay. Remember, delayed nausea and vomiting is a very important mechanism to manage. And therefore, remember that for delayed nausea and vomiting, dexamethasone plus aprepitant are important agents to use, as is the antipsychotics. Now, coming to the ILD. Now, the reason I've also gone a little bit quickly is to give the pulmonologist a bit of time in the session, because this is going to be an important thing to manage. Okay. ILD or pneumonitis in these patients presents with cough, shortness of breath, fever, or worsening or new respiratory symptoms. Patients need to report this as soon as it happens. So in my unit, these patients have a direct line to the nursing sister that manages these side effects. So the moment they need to inform us. Okay. So the moment they have this, the patient will need to come in. Okay. For grade 1, we give them corticosteroids. Okay. Corticosteroids. Now, remember, when they arrive, we have to look at radiological investigations, and the radiological investigations are not easy. By and large, a chest X-ray is largely a waste of time for these people. We do high-res CAT scans. You don't need contrast, but you need a high-resolution CAT scan. And I mean, in our institution, these scans take roughly under 5 minutes to do. So it's not like the normal scan we use for disease assessment. This is purely looking at the lung, but I'm sure the pulmonologist will tell you more. You wait until recovery. You wait with the TDXT until recovery. If it gets better in under a month, you're fine. You can continue at the same dose setting. This is for grade 1. If it does not get better in under a month, you wait, and then you have to dose reduce 1 level. If there's grade 2 interstitial lung disease, you need to give them much higher doses of steroids, and the steroids you give them, you need to have for at least 2 weeks, after which you start tapering for the next. Here's your big problem. Anything more than a grade 2 will mandate the discontinuation of the TDXT. So it's very important to manage this. Okay, so what do you need to do for these patients? Okay, so before starting TDXT, you need to see what lung functioning there is. So that'll mean that patients needing TDXT need a CAT scan of their chest. Okay, you need to confirm that there's no issues with ILD or pneumonitis. You check for risk factors. Okay, do they smoke? Do they have COPD? Do they have previous history of any interstitial lung disease? You need to listen to them, and you need to do pulmonary function testing. Okay, I'm fortunate where I work. I'm literally 150 meters away from a pulmonologist/intensivist. Okay, so patients going for TDXT therapy get to see the pulmonologist up front to make sure that the lungs are clean. Like with the old monoclonal antibodies, we should check the heart all the time. These patients, while they're on TDXT treatment, need a CT of the lung every 8 to 12 weeks. So what I do is I do it around 9-10 weeks. Every 9 to 10 weeks. Because remember, grade 1 ILD is actually literally stuff that they may not even notice. So therefore, it's important to check this. They need pulmonary function testing, which is purely just blowing into one of their machines. I'm sure your pulmonologist will explain this to you, at least every 4 to 6 weeks. It's very important in the scenario to be able to work with a pulmonologist when managing these patients. Okay, when they come, they get their vital signs looked at, and they got a simple oxygen saturation every time they come in. A walk test is interesting. Most of my patients survive the walk test because my office is actually probably about 20 meters from the reception. So if the patient arrives at my office and they're not short of breath, I usually know they're okay. They can have their next dose of treatment. Remember, you need your radiologists also involved because they're the ones that are going to do the scanning with you. And sometimes to look at ILD is somewhat subtle. Okay. Remember, grade 1 literally only has a dyspnea, cough with a fever. So it's very important these patients call in to you the moment these things occur. Grade 1 is asymptomatic with only radiological findings. Grade 2 is symptomatic with the findings, but they are limited. Grade 3 is when it's severe, and grade 4 is life-threatening. Grade 3, oxygenation is required. So remember, what are the cornerstones of the management of this? You actually have to keep an eye on the patients very closely. Number 2, corticosteroids, oral or intravenous, is the cornerstone of therapy. You stop therapy, or you may discontinue therapy indefinitely, particularly if it's grade 2 or worse. Okay, so it's very important, again, I hate to sound like a stuck record, but you need to keep an eye on these patients very closely and monitor them. So if you suspect ILD or pneumonitis, you interrupt drug. You rule it out by looking at the radiological assessment and assessing the signs and symptoms very carefully. Evaluation needs to be by high resolution CAT scan. You get hold of your friendly pulmonologist, they're always willing to see you. Blood cultures, full blood counts, and all of those tests are routine tests I do before each of these occasions. Bronchoscopy and BOL is stuff the pulmonologist will mention to you, I'm sure, and pulmonary function tests. Pulse oximetry is very easy to do, especially in the COVID era. All of us have those things now lying in our cupboards, which hasn't been used in forever. You snip it onto their finger, and you can see what the oxygenation is. Arterial blood gases and all of those things only become significant once they have grade 2 plus. They are admitted, they're in a hospital or in a high care or ICU facility, in which case all of these tests become mandatory. If it resolves within 28 days or a month, you can then continue. If it takes longer, you go down one dose level. If it doesn't get better, I'm afraid you'll have to permanently discontinue therapy. This is now in terms of management. I'm sure the pulmonologist may go into this with greater detail. Grade 1, it's 0.5 milligrams per kilogram per day of prednisone. Okay? You start for the first week, and then you taper over the next 4 weeks. Grade 2, you're going at 1 milligram per kilogram per day of prednisone, the equivalent. You'll keep it at that dose for 2 weeks before tapering over 4 weeks. If it's grade 3, grade 4, they're going to be requiring IV methylpred up to 1 gram a day for 3 days before tapering. If there's no improvement, you're going to have to worry about getting them other immunosuppressants, depending on what you would use in your local scenario. So what do you tell patients? You tell them if they got a cough, if they got a fever, or if they're short of breath, they need to tell you straight away. You bring them in and you scan. Why? Because ILD is life-threatening or fatal. Okay, and therefore you have a checklist and you inform the patients so they can do all of these things. Now, I didn't mean to scare any of you with this product, but I just thought I'd finish this with a story of a patient that I have. She's now 42, presented to me at 33 years of age in 2016. She presented to me with triple positive breast cancer. Just by the by, her dad was diagnosed with prostate cancer 2 years ago. Okay, I made the diagnosis and then he was managed for this. She had a T1N1, T2N1 M0 triple positive breast cancer. She was treated with the neoadjuvant at the time, ACTH, with the GnRH. Okay, excuse me. On the 30th of September 2016, she had a wide local excision post neoadjuvant chemotherapy. The result post neoadjuvant chemotherapy was a T1C N1 breast cancer, M0. She got adjuvant chest wall radiation thereafter, and she continued for the balance of her trastuzumab together with endocrine therapy since she was triple positive. Endocrine therapy included in a 33-year-old lady, an AI plus Depo GnRH every 3 months. Incidentally, BRCA testing was done upfront because she was less than 40 years old, and there was no BRCA germline mutations noted. Okay, so this was in 2016, completed Herceptin and stayed on adjuvant endocrine therapy. In December 2020, she presented with her first relapse, hepatic, left chest wall, and osseous metastases. I started on docetaxel and then with trastuzumab and pertuzumab. She got the combination together, docetaxel for 6 cycles, and she continued pertuzumab, trastuzumab doublet together with zoledronic acid and tamoxifen. She was treated until December 2021. That was the histology. ER negative, PR negative, HER2 positive. The KI was now 49%. I requested somatic BRCA in the hope that I'd find something that could be targeted. That was negative. And you can see that further testing on the NGS testing showed a PI3 kinase mutation, which is one of the mechanisms by which people are become the dual targeted therapy does not work anymore. The HER2 was confirmed as amplified on NGS, and she had a MYC abnormality with a 6-copy gain. Incidentally, in 2021, she saw a gynecologist. She had developed CIN, for which she did a TAH and BSO. She did the TAH and the BSO because the BSO was done, which is a bilateral salpingo oophorectomy, because it has therapy for the luminal component of her initially diagnosed triple positive breast cancer. Unfortunately, in March 2022, a PET scan demonstrated extensive active nodal disease in the chest and the abdomen with multiple hepatic metastases, new hepatic metastases. There was the osseous metastases showed ongoing response, and indeed there was sclerotic. Okay? At this point, we changed the therapy to capecitabine and trastuzumab. Please be advised that TDM1 was available, but we did not give a TDM1 because it was not at that time reimbursed by her insurance, and she was not in a position to fund the TDM1. Okay, she was given 3 cycles of trastuzumab and capecitabine, and unfortunately, by May 2022, she was diagnosed with disease relapse. There was new hepatic metastases, new nodal metastases, and the abdominal nodes were much larger. So this was the 3rd line therapy. TDM1 was initiated, zoledronic acid was continued. This was maintained until February 2023, when the CAT scan demonstrated new hepatic lesions, confirmed on a prima vista MRI. Okay? At this point, conversations regarding trastuzumab deruxtecan was initiated. There was going to be a problem in terms of co-payment issues, but it was decided that she was in a position to help fund this because it is an unregistered agent. And you can see there from when this has been unregistered in South Africa. Okay, it was an unregistered agent in the country, but we managed to get some in for her. So she started in March 2023 and has responded extremely well to therapy. In July 2023, we demonstrated oligoprogression in a single MET in the liver. Everything else was controlled, and everything else was indeed getting better. This was confirmed on prima vista MRI, and we treated that single MET by stereotactic radiotherapy. Then continued her on the TDXT. In October 2024, she showed a solitary frontal lobe MET, presented with just recurrent headaches. We did an MRI of her brain, and she showed the solitary frontal lobe MET. It was treated by stereotactic radiotherapy, and she continued at TDXT until the 5th March of 2025. Here's the scans that show you that was in 2023, that's in 24, and that's in October 24. And you can see that she's been responding very well to therapy through this time. Okay, that was when she had an MRI of her brain, and that demonstrated the single metastasis. And you can see after stereotactic radiotherapy, completely fine. Okay, however, in March 2025, she presented with significant chest disease, mediastinal disease with a big mass. So she will get a biopsy. Interestingly, she's had no ILD. She's had no nausea, no vomiting. Okay, but she has tiredness, significant tiredness, and she's had hair loss. Okay, so she's got her hair. She's probably lost about, if I were to consider a head of hair, about 50% of the hair on her head. Okay, she gets tired in that she's man down, quote unquote, for about a week. Okay, after which she can rise and manage her her 2 children. One's her own, and the other one's her husband. Okay, so she now needs to have a biopsy of her chest mass. We have treatment options to give her TKI plus capecitabine plus trastuzumab. It depends which TKI I choose, depending on what the chest mass biopsy shows us. When I said TKI, our choices are obviously lapatinib and or naratinib and or tucatinib. Tucatinib would be the ideal choice because there was brain metastases. However, tucatinib is not easily available in South Africa and it's pretty expensive. She might be a candidate for a next line drug antibody conjugate. There are a whole lot of new ones available. That's a possibility. Of course, we might decide to go back to, just like we did in the old days, single agent chemotherapy with trastuzumab. And the other reason for biopsy is, you must remember that these are also hot tumors, so she might be a candidate for immunotherapy as well. I thank you for your attention, and I'd like to hand over to the pulmonologist so he can tell you a little bit more about how to manage the ILD. Thank you.
Thank you, Dr. Moodley. I think that was an excellent presentation, and I'm sure we'll have some questions, especially regarding the case. But important to note, this patient has had disease for 9 years and is still going. So having a metastatic disease does not necessarily mean a shortened lifespan. So we'll hand over to Dr. Andrew Owor. Andrew? Dr. Andrew is a consultant pulmonologist working at the Kenyatta National Hospital. They have a strong program with the Respiratory Society of Kenya. I think there's an ILD clinic at the hospital. They also have an ILD tumor board. So I think he's best placed to talk to us about the potential for ILD in when we're using the TDXD. Welcome, Andrew.
Hello. Hi. Here in Kenya, we say you put it in your lungs, not in your heart. So be glad. I know it's late in the evening, but I'm a pulmonologist. And as a pulmonologist, you have to have some sense of humor. That's how sometimes you know what the problem of the patient is. If a patient has a respiratory condition and you crack a joke, and they start coughing, you know you're onto something. So I'll share with you that first secret. So as Dr. Moodley had said, he says a patient walks, the next thing is to crack a joke. If a patient starts coughing and they're on TXD, then you know there's some trouble coming up. So thank you so much for the invitation, Kesho and AstraZeneca, once again to your meeting. I am soon, I think I'll put there /oncologist, because I think every year I get an invite from the oncologist. But as you well know, unfortunately, 80% of your malignancies will end up where? In the lung. Unfortunately for us, we're usually called right at the end. Today our topic is different, and it's basically, I'm just going to give you the role of pulmonologist. I'm not going to go so much into detail. Dr. Moodley has already talked much about it. A disclaimer, although I don't have much recommendations here, but I was told I have to put up this slide. So our outline is overview of mechanism of action. I think my colleague, Dr. Njiraini, had already touched on the mechanism of action and how this drug works. The other thing is an interstitial lung disease. Maybe to some of you, this is a new term. I'll just go a little bit over that. And then how to recognize symptoms. My able colleague has already done a lot of work for me. And then management strategies is also touched on it quite comprehensively, I must say. I almost asked myself if he doubles up as a pulmonologist. Today I've learned some things. FAM, trastuzumab, deruxtecan, and XKI. That's a mouthful. But this is targeted therapy, and we're moving to the era of targeted therapy for most of the cancers. This drug is used for breast, gastric, and I think soon also for my bread and butter, lung cancer, because some lung cancers will also express HER2 receptor. And this drug is combined, and it's important to know that you saw it mentioning ADC. That's part of how it causes also the problems. I'll not go so much on the mechanism, but it's important to know the side effects. They mentioned about nausea and vomiting, but pulmonary complications are probably the most crucial for this treatment. So what are interstitial lung diseases? Interstitial lung diseases are a broad group of diseases. For us in pulmonology, there are about 200. But I'm not going to go through all that. I'm just going to restrict myself to what we call drug-induced interstitial lung disease. So this is a group of entity of diseases that usually cause scarring of the lung. So there's inflammation, and then there's scarring of the lung. And if you very well know, gaseous exchange occurs in your alveoli. So if your alveoli gets inflamed and it gets scarred, then your oxygen, which is used to just walking 30 centimeters or just crossing to the blood, now has to walk about 1 kilometer. And that's why there is problems with what you call gaseous exchange or diffusion of oxygen into the bloodstream. And that's how the problems actually come in. That's what will actually usually manifest as the symptoms. So the pathophysiology of this will be either direct toxicity, as you've been told, you have HER2, and then inside there it is deruxtecan. Okay? So deruxtecan is quite a good dose of it. I was reading about 5.4, was it 10 milligrams? So per kg. So there's a lot of medication going in there, and that could cause problems, especially with the lungs. The lungs receive about 5 liters of blood every minute, and they have to sieve it. So there is one direct toxicity to the lung, courtesy of the drug, and then also there is the antibody-dependent toxicity that also happens with this drug. And that's how you end up with the interstitial lung disease. Symptoms. So here they mention cough, but since Dr. Moodley had already put it quite evidently, by the time the patient has a cough, we are late. Remember that. By the time the patient has symptoms, we are late. And we are probably not going to use our good drug. So we want to catch these patients before they have symptoms. So the symptoms are, I probably reverse them. They say cough, but for me, shortness of breath is actually the earliest sign. So that's the only one that you'll pick before the cough shows up. Because if the cough shows up, then there's already a lot happening in the lung. So shortness of breath. And for us in pulmonology, shortness of breath is the most important symptom. And it's the most scary of symptoms. So if the patient was able to climb stairs, you want to ask them, are they still able to climb stairs? If they say they're having difficulties, then you need to investigate a bit more. Okay? They may also have fatigue. There's a difference between fatigue and shortness of breath. Right now, I'm quite fatigued. I'm a pulmonologist. Okay, today we had our chest clinic in Kenyatta. You see patients until you actually are fatigued. But I was able to climb a flight of stairs all the way to 7th floor. Okay, so I'm fatigued, but I can exert myself. So don't confuse those two. When the patient can't exert themselves, there is a problem. They may also have fever. And fever just means there's systemic things going on. Who are the high-risk patients? Maned, you talked about patients that are on TXD. We want to ask how many of those patients are above 60? None. Okay? So for me, the greatest risk factor is age. Now, breast cancer in our country, more or less a young women's disease. But I guess as you continue doing the good job that you're doing, our breast cancer patients will continue living longer and longer. And probably over time, it may reflect what they see in the West. because their patients are a bit older. And that's why it's more of a concern there. I don't expect to see much here. With the experiences with the other drugs, we haven't seen a lot. The patients that I've seen who've gotten pneumonitis, usually lung cancer patients, on biologic therapy, on TKIs, but the patients that I've seen, they were above 70. So younger patient might actually protect ourselves. We may not see that much. The second thing is patients who have any respiratory comorbidity. So one is COPD. For us, again, COPD cutoff around 45. So if you're treating 29-year-olds, 33-year-olds, I don't anticipate much. But if we start seeing, then perhaps it will be something to be worried about. The other thing is other lung conditions. In literature, they didn't mention asthma, because that's the one that tends to affect people who are a bit younger. So age would be one. Second would be gender. I think this has not been captured. Do you have male patients with breast cancer? So male patients are going to be high risk. Okay, if there's a male patient who will qualify for this drug, their risk is going to be a bit higher than a female patient. And then lastly is if that patient has any other problem with the lung. And then when we start using this drug for lung cancer, we will see interstitial lung disease. So how do we detect these patients early? Assess for dyspnea. Assess for dyspnea. The second thing is your stethoscope. How many of you have a stethoscope in your office? Oncologists. Peter, do you have an... We work a lot with Peter, Sidney, and Joki. If you're seeing these patients, you will need to have your stethoscope. And the reasoning for this is, yes, for these patients, you need to do a CAT scan, high-resolution CT. But how do you know who you need to send for a CT? Either the patient is symptomatic, okay? If the patient is symptomatic, I've already told you they're in grade 2. So you might actually consider stopping that drug altogether. Now, there's something in the literature that they say, it's called, in pulmonology, you call it Velcro crackles. Okay, Velcro crackles. These are inspiratory, mid to end inspiratory, fine crackles or crepitations that are usually most commonly had at the bases of the lung, so usually on the posterior, the back. And that's why you see us pulmonologists walking around with stethoscopes that you can actually increase the volume and reduce and actually record. So for me, when you're managing these patients, you also want to listen carefully at the bases of the lung with your stethoscope. Tell them to take a deep breath in and out, and here, if you hear that, there's ILD. Send that patient for a CAT scan. So our role as pulmonologists is just the way I think they'll be doing echoes for most of your patients on Herceptin. Here you will need to have these patients having a full pulmonary evaluation prior to initiation of treatment. And this perhaps will usually involve having a high-resolution CAT scan prior to initiation of therapy, lung function testing, which may include spirometry, and diffusion capacity to actually be able to see if they are anatomical or functional disorders. Anatomical disorders, you'll be able to see them in your high-resolution CT scan. Unfortunately, you can't make a diagnosis of COPD easily with a CAT scan unless there are obvious signs of emphysema. So for that, you'll need to do lung function testing to actually make sure that this patient does not have underlying lung condition. At the same time, you will need to do oximetry for this patient. Now, I know most of you are from other parts of the country, and you may not have a pulmonologist next to you, but basically just do the basic things that are required. So baseline, high-resolution CT scan before initiation. Minimum, at minimum. And then, as Dr. Moodley had said, every 10 to 12 weeks, you need to repeat. And there needs to be that collaboration between the oncologist and the pulmonologist, stroke, internist, or physician. When it comes to diagnostic criteria, it's basically the evaluation, either symptoms, imaging, or functional testing. And then you'll want to also rule out, because there are many things that could be happening for this patient. And that's why, for example, Dr. Moodley had mentioned sometimes you may need to rule out other things. Does this patient have an infection? In Kenya, tuberculosis is endemic in most of Africa. So I am sure there'll be some patients who either come down with TB or previously have had tuberculosis when they're undergoing chemotherapy. It is not unusual. We see these patients. We may need to tease out these patients. So our role, my role as a pulmonologist is when you're not so sure, then you'll need to call us to actually try and tease out for you, is this an infection or not? But by and large, if there's no fever, then more or less, and then you hear those crackles, more or less it's ILD. If there is fever, then you want to check, is there infection? And the other things that we probably need to do here is what Dr. Moodley had mentioned. If there infiltrates in the lung, we'll need to do a bronchoscopy, do what you call a bronchoalveolar lavage, to actually check if there are any infectious causes of what you're seeing in the CAT scan. And for us here in Kenya, tuberculosis is number one. Aspergillosis, which is a fungus, notorious, very sometimes quite difficult to find and difficult to treat, but you need to look for it. So those are the things we would need to do. If the patient is coughing and is expectorating, then of course you do the usual test, sputum microscopy, and then you can do a sputum expert test as is standard for patients. But generally for ILD, they'll usually be unproductive. It's a dry cough. Management, Dr. Moody had already gone through the management protocols. I'll not belabor the point. Apart from patients who have imaging or anatomical abnormalities, once a patient has symptoms, by and large, we may need to stop. Hallmark of treatment is actually steroids to halt the inflammation, and then we need to continue doing the assessments to see once this drug has been stopped, whether this patient has a comorbidity. Do they have COPD? Do they have another cause of interstitial lung disease? Or is it just, and are they recovering? So we want to see if it's drug-induced, when we draw the drug, we anticipate that the lung function should improve. If the lung function doesn't improve, then we are quite a bit of a bind, because this patient may need to be on immunosuppressants. My last slide is collaboration. So one, interdisciplinary communication. These are patients who, at think when we start, will need quite good follow-up between the oncologist and the pulmonologist. For me, my request as we start this, please, AstraZeneca, if we could do this as a study. For those of you in the university or in the tertiary facilities, as we initiate this, maybe one of our fellows or residents could also do this as a study, so that we actually have a true picture of how our patients behave. As my teacher Dr. Gladwell had mentioned, how many Africans were in the study. This will be a way of us knowing how our population will fare with this treatment. Patient education, I think the last slide of Dr. Moodley was actually a question that you need to ask patients. Are you experiencing shortness of breath? Are you coughing? Okay? Do you have fatigue? Sometimes patients will confuse fatigue and shortness of breath, especially ladies, because majority of your patients are going to be female. For us, the greatest challenge as pulmonologists, whenever you ask a lady about shortness of breath, they want to attribute it to either their weight or their age. It's very, very difficult, because in pulmonology still, majority of our patients tend to be female, apart from men who smoke. So most of the asthma will be mainly in female patients. And it's a struggle sometimes, because to tease out that history of shortness of breath, because it's the most important one. If you miss it, then the patient will only come to you once they have frank symptoms. That one you have to get it out of the patient. When the patient is coughing, they'll show up to your office and tell you that they are coughing. Lastly is research, for us to be able to understand this drug better and see if we'll be able to come up with different ways to actually refine our strategies and be able to take care of these patients. Thank you.
Thank you, Dr. Andrew, for those insights and the issue about communication and multidisciplinary care. So we are going to move away from toxicity to talk about HER2-low breast cancer, which was one of the questions that was asked. Is there a benefit for Enhertu in this subgroup of patients? and is there a difference? So first we'll get a perspective from our pathologist, from Professor Shaheen Syed. She's the Gen Z. So Prof is a renowned pathologist. She's the head of department and lab director at Aga Khan University Hospital. She does a lot of research in breast cancer and is passionate about enhancing access to molecular markers and IHC. And she's going to talk to us about the changes in the HER2 paradigm from a pathology perspective. Welcome, Prof. Shaheen.
I hope I'm not going to, am I the last? No, I'm almost the last speaker, right? So I'm going to try and not keep you too long away from dinner. And to Manel, thank you for promoting me to a Gen Z. So today we will just touch on the diagnostics aspect. And I hear a lot of people always asking, what is HER2 and have you started reporting HER2 when you're doing your HER2 testing? So I thought we'd just, of course, this is the disclaimer. And just to give you a sense of the objectives of the talk is to provide you an overall overview of the role of HER2 as a predictive marker in breast cancer, and then recognize the evolution of HER2 testing over the years, provide some new perspectives in the spectrum of HER2 expression, and that's where the HER2 low comes in. And then understand the challenges that we as pathologists face when we are scoring the HER2 across this full spectrum. So I won't go over the case studies for today. So we know that in terms of breast cancer, we know very well that it's a heterogeneous disease. And that we need to test for HER2, just like we need to test for ER and PR. We need to test for HER2 for all patients who are newly diagnosed. And then in the MET setting, we should reassess at least once. And if clinically feasible, so that you can inform the diagnosis. And we know about the molecular subtypes of breast cancer, so HER2 positive, in terms of prognosis, has a moderate prognosis compared to luminal, which has always had the best prognosis. And then, of course, once the biomarkers are done, there's a staging, and then the treatment decision, which is based on the clinical staging, as well as the histopathological features and biomarkers. In terms of the role of HER2 in breast cancer, we know that when HER2 dimerization occurs, you have a downstream receptor tyrosine phosphorylation, which then promotes downstream signaling pathways that leads to tumor growth and metastases and invasion. Now, in terms of the history of HER2 positive breast cancer therapies and testing, way back in the early 1980s, the HER2 gene was identified in 1984, and then in 2000, the first anti-HER2 monoclonal antibody was approved, and then the first tyrosine kinase inhibitor was approved in 2008. So around 2007, that's when ASCO-CAP came up with the guidelines for HER2 testing, and these have been revised over time. So initially, they were anything less than 10%, as a score was considered, 10% was the cutoff initially for calling it positive, but then over time they found that, perhaps there are too many false negatives, so they went up to 30%, then they found, false positive, they went to 30%, then they found out that perhaps there was a lot of pre-analytical issues and analytical issues that were giving rise to these false positives, so went back to 10%. In 2018, we have the ASCO-CAP HER2 guidelines. And then from 2020 onwards, we have one revision, or not a revision, but an update. In 2023, the ASCO-CAP HER2 testing guidelines were updated. So when it comes to, like I mentioned, there's an algorithm of how you do the IHC, or the immunohistochemistry, and the FISH, or the ISH assays. And most of these countries across Europe, for example, have created some sort of versions or modified versions of the ASCO-CAP guidelines. So, like I mentioned, in the early 2000s, HER2 positive was defined as HER2 3+, and it was more than 10% of your cells must be strongly membrane positive. But as over the years have passed by, we have gone through, like I said, the 30% rule, then the 10% rule that came back. In 2019, the German society updated their guidelines. In 2022, the Royal College of Pathologists updated their guidelines. The French guidelines were updated in 2021. ESMO and ASCO were updated in 2023. So usually what you see is that the ESMO, ASCO-CAP guidelines are usually similar. And so these guidelines, like I said, have emerged and evolved over time to update and improve standardization of the HER2 testing, and making sure that the results and the testing is consistent over across all the testing sites. So now, what about the UK updated? So I said the UK guidelines were as well updated, and currently they include HER2 low preparation for the approval of the targeted. So in the UK guidelines, they promote consistently to further refine definitions of the HER2 status. However, despite the fact that we're dealing with HER2 low in the TDXD context, the UK guidelines say do not require a change in practice in the terms of how you test. So they say you need to continue, labs need to continue to use their approved HER2 assays. So how have they refined it? One, they say provide focused training to the pathologist to be able to recognize the staining intensity and staining patterns across from 0 going right up to 3+, to increase the reproducibility of 0, or is it 0 or is it 1+, they say go to a higher magnification. So if you have a microscope, go to ×40. And then the third thing is you need to ensure that you have control preparations on the same slide. So the way we do it currently is where we have, okay, so we have a 3+ control specimen on the slide, and then we compare that with our test result. But currently, the current recommendation is that you should have 0, 1+, 2+, 3+ as control specimens on the same slide for you to be able to accurately classify your HER2 test. And then again, this hasn't changed, is that you need a reflex ISH, whether it be dual ISH or it be FISH with immunohistochemistry only for 2+. And then the other recommendation, and again, even CAP ASCO recommends that, is that if you are in doubt, show it to a second pathologist. So don't sit back and say, well, I think this is 0, I think this is 1, I'm not so sure, but I'm going to sign it off as this or the other. So you need to show a second pathologist as well. And then for the ESMO expert consensus guidelines, if you look at how they've defined HER2 low, it is incomplete or faint staining in more than 10% of invasive tumor cells, which would be your HER2 1+, which is currently considered to be HER2 negative, is now, according to the ESMO 23 guidelines, is considered HER2 low, but according to the CAP guidelines, and which we all follow, is still a HER2 negative, and weak to moderate staining in more than 10%, but it is ish negative, meaning you've done a fish, it's a 2+. It is equivocal on immunohistochemistry, but then when you do an ish test, be it fish or be it dual ish, it becomes an HER2 negative. So any 2+, which is an equivocal, or any 1+, is considered HER2 negative, but by ESMO guidelines, you'd call it a HER2 low. Now, the ASCO cap says, as a pathologist, I need not say that I need to be the one to make sure that for the benefit of the patient and for the benefit of the oncologist, the way I need to help out as far as the testing and the scoring is concerned is to ensure that I am very sure that a 0 is a 0 and a 1+ is a 1+. So that's my, and then the 2+, which goes for ish, and it can be a negative, and that's a HER2 low, or if it goes to positive, then becomes a HER2 positive. So my function as a role as a pathologist is to ensure that I do not, for example, undercall a 1+ as a 0. So that's the main, and the main issue here is to make sure that the assay is right, the pre-analytics are right, as well as making sure that if I'm not sure, then I have to show it to a second pathologist. So when you look at the, like I said, the ASCO CAP HER2 guidelines, which were updated after the publication of the Destiny 04 trial, and the reason ASCO CAP says, as a pathologist, I should not say HER2 low, because the Destiny 04 trial did not include HER2 0. It only included the 1+s. So because of that, they say you shouldn't say, because how sure are you that because the eligibility of TDXD was based on the trial participants' outcomes, right? And the selection of the trial participants. So if you did not include the HER2 0, how sure are you that the HER2 0 would not have also benefited from TDXD, right? So then, so the guidelines again, similar, that you use a high power view. So not a low power, you make sure you go right up to the high power view of the microscope to be able to distinguish between a 0 and a 1+. And then second pathologist, again, like I'd mentioned, on-slide controls with a range of protein expressions to include a 1+. And then the careful making sure that the pre-analytics, and pre-analytics plays such an important, people sometimes undermine the effect that pre-analytics can have on the downstream testing of some of these tissues. In terms of how can labs help ensure eligibility for TDXD without a HER2 low category, like I said, you have to, in your report, make sure you don't just say negative, you say 0, this is 0, and this is a 1+, and it's a 2+ and a 3+ in all our interpretations. And this, according to CAP, ASCO CAP, is sufficient for information for the physician to make, or the oncologist to make a decision whether this patient is, patient sample is a HER2 low and therefore eligible for TDXD. And then in ASCO CAP again, they just say you can make a comment. So the updated 2023 guideline states that you report a 0, 1, a 2+, and 3+, and at the bottom then you make a comment that this, you know, this would be eligible. Someone like a 1+ would be eligible for a TDXD therapy in the right clinical context. And that's, and the other thing about HER2 standardization is that over the years, initially there used to be, I'm sure you all heard about how there used to be such a discrepancy between the local testing lab and the central testing lab when these clinical trials were going on. But over the years, remarkably, what has happened, because of the pre-analytics, that has a lot of attention that's being paid to pre-analytics, a lot of education, awareness among the pathology societies, the discrepancy and the discordance has really reduced. And that's specifically for 3+ versus negative. Is it a 3+ or a negative? But now we are coming back to the same problem that pathologists amongst themselves to say, is this a 0 or is this a 1 plus? Quite a lot of discordance currently. So we know that traditionally this is how HER2 has been classified, but now we have this HER2 low category, which is a HER2 1 plus or a HER2 2 plus that is not amplified. So then someone, I think one of the speakers mentioned about how the HER2 expression, low expression or the HER2 expression may have different clinical features. It's interesting to see that there's a study from a retrospective study, and they looked at the HER2 negative data sets, wanted to see is there a difference between a HER2 low and a HER2 0 disease or totally negative. And they found that low levels of HER2 are more frequently hormone receptor positive rather than triple negative, and this was clinically significant. And they have a larger primary tumors, more nodal involvement than a patient who has a completely HER2 not disease. And they are found less often. So HER2 low are found less often with high histologic grades compared to HER2 not. So in terms of, when looking at HER2 low, what are we talking about? Up to 60% of cancers previously classified as HER2 negative can now be reclassified as HER2 low, because these are those 60% who are either 1 plus or are 2 plus who are not FISH amplified. So up to 60%. And so it's a clinically actionable population, especially, of course, for advanced breast cancers. So that is the reason why more and more the emphasis on can you differentiate, make sure you differentiate in a very clear in your mind that this is a 0 and this is a 1 plus. And then in terms of heterogeneity, in equivocal IHC results are very, very common cause of equivocal because of tumor heterogeneity. So tumors that demonstrate this heterogeneity are usually of higher histologic grade. Lymph node, they express, usually go to the lymph nodes as well. However, when you look at the increased heterogeneity, there's no significant prognostic difference between low expressing and HER2 not disease. So in terms of how do you, when you compare the one, but you get this proficiency test from the College of American Pathologists, and when you compare pathologists' interpretation, you find that the concordance, and they did this study and they found that the concordance for the 3 and the 2 plus was almost very excellent. But when it came to 0 and 1, it was just around 70%, which is not good. Because usually we say for any biomarker, you have to have a 95% concordance between me and someone else. So having a 70% is not that great. However, the only limitation of this study is that they used what we call TMAs, where you have very small tumor samples on many tumor samples on one slide, but the tumor sample size is very small. So they felt perhaps that could be a limitation in the sense that the heterogeneity of the tumor could not be established when you have such a small sample. So poor scoring accuracy among pathologists, and therefore which may then misassign patients in terms of treatment, buckets. So the question is, these results are not good. So therefore pathologists need to take more time, more careful examination, and it's easy at a low magnification, and we are currently at tumor boards, even the oncologists can say, oh, this is a 3 plus. And sometimes they say, oh, but are you sure this is a 3 plus? It looks like a 2. Are you sure this is a 2 plus? It looks like a 3 plus. So it's that easy these days between a 3 plus and a not. but when it comes to 0 and 1, it can be a challenge. So then, where does the issue lie? The issue lies in the biopsy type, how we handle samples, the cold ischemic type, and the type of assay that your lab is performing. So when we come to the biopsy site, we know that we use core biopsies for all our biomarker testings. However, because of the limitation of the size of the biopsy, you may miss out on tumor heterogeneity, meaning some areas that are positive or low, and some area HER2 low, which is 1+, and some areas that are negative. So you may miss out on those. And then because most of the time you pick with your forceps, you may crush the biopsy. And when you crush the biopsy, there is what we call an edge artifact, a crush artifact, and so you may call them falsely negative or positive, depending. So a new test on an excisional biopsy, therefore, may be ordered when the tumor is grade 3 on a core biopsy. The invasive component is on the core biopsy is small, and then the presence of perhaps testing errors, like I mentioned, maybe crush artifacts. If those are impacting the pathologist's interpretation, then you reorder the HER2 on the excisional biopsy to make sure that you're not missing out on these low. And then what about the MET site versus the primary? So if you have a primary, you test, but in the MET setting, you test again. And the reason is you have to test because, again, the HER2 status may change. It could from a negative to a positive. And the biopsy site, however, many of the HER2 breast cancers go to the bone. And that's another issue for us as pathologists when we get bone biopsies for biomarker testing, because it all depends on what you use to decalcify the bone. You cannot do testing straight away. You have to make sure that you remove the calcium from the bone to be able to do your biomarker testing. So there are many, many ways we do this. We can use EDTA, we use formic acids, people use nitric acid, hydrochloric acid, to be able to decalcify the bone. The problem is when you use those decalcification agents, some of them are really, really harsh to the effect that the antigenicity is lost. So your lab, I mean, this is just an example to show you, that is a controlled specimen with a 3+, using an EDTA, which is a chelating agent. It binds to the calcium in the bone. You see that the EDTA is doing pretty well, but then when you use a formic acid, sort of a decalcifying agent, it becomes sort of a 1+, and then the same specimen. And if you use it with the microwave just speeds up the process of decalcification. And if you use it on the formic acid on its own, then you find that it's giving it a 2+. So according to the I've got 5 minutes, decalcifying agents with EDTA are the ones that your lab must use. So if they use anything else, it's likely that they're going to get false negative. So you have to be aware of that as well, even as oncologists and physicians. And then sample handling. HER2 signal intensity decreases over time. So you want to make sure that your sections, so when you cut tissues from a block, should not have been stored. You should not have, the lab should not have cut your slides and kept them unstained for more than 6 weeks and then bring them out and start staining them. As you can see, the more you keep them in storage, the less likely it is that you'll get a accurate result. So that's case number 1 for less freshly cut section. And then when it's on 6 months, you can see the whole scoring changes. What about cold ischemic time? Within an hour, your core biopsy must be in formalin. If it is not, again, it affects, right? So 48 hours, if you keep your biopsy out for 48 hours without putting it in formalin, that's what happens. You're going to get a not HER2 0 result. What about the type of assay? So these are the different types on different platforms. I'm sure you've heard of Mentana, you've heard of DACO. So those are the various platforms we use in the lab. All of them sometimes have the different specificity and sensitivity. The CAP ASCO guideline states that FDA-approved assays must be used. So you can't just, you could use lab-developed assays, but they have to be validated. But the guidelines state FDA assays. And what about, as you can see, the 3 pluses and the way they look on the various platforms, right? So the 3 pluses on the HERCEPT test, on the pathway, on the Leica system, so the 3+, and the pathologist should be able to sort of interpret each. Some are less intense than others. And this is the 2+ on the various platforms. Again, you can see the HERCEPT test is less intense than, for example, the pathway. So the pathologist, again, needs to be aware of this, okay? Okay, so like we mentioned that the differences between 1 and 0 and 1+ are very subtle. I've already explained to you what the pathologist needs to do. And then in terms of the guidelines by ASCO, and I'll only focus on the ASCO and because of time, this is the narrative at the bottom. They say patients with breast cancers that are HER2 3+ or ISH amplified are eligible for all these therapies that disrupt HER2 signaling pathways. However, those that are 0, 1, or 2+ not amplified are specifically considered HER2 negative for protein expression, since non-expressed, overexpressed levels may be present in these cases. Patients with breast cancers that are HER2 1+ or ISH non-amplified, 2+ but non-amplified, may be eligible for treatment that targets non-amplified, non-overexpressed levels of HER2 expression for cytotoxic drug delivery. And this is the latest update from, and that's what we should be putting down as a narrative, but ensuring that the scoring is very clearly 0, 1, 2, and 3+. And then these are the other ones from the Royal College. The Royal College says, well, if you have a 0 and a 1+, call it a HER2 low for the sake of the physician. So then the most important bit, however, is when it comes to any biomarker testing, I think it's important, as Dr. Andrew mentioned, that we need to ensure that we have a multidisciplinary team effort. It starts right, whether it's from the pathologists, the physicians who ordered the test, the researchers, the patient. We have to make sure that it's a multidisciplinary effort, because without that, I think we risk doing the wrong thing for our patients. And so in summary, like I mentioned, HER2 testing guidelines recognize the emergence of HER2 targeted therapies and the potential benefit of in patients with HER2 low expressing breast cancers. Up to 60% of breast cancers classified as HER2 negative, they will express some form of HER2, IHC1 or IHC2+, which are HER2 ISH negative, and these are then eligible in the correct clinical context for your TDXD therapies. So as a pathologist, what we need to do is to adhere to HER2 testing recommendations to ensure that we are consistent in the way we report our HER2, and that we need a lot of collaboration and understanding and creating that awareness among physicians and pathologists as well, and that as pathologists, we need to also focus on training more and more, ensuring, having refresher trainings of how to do a 0 and making sure that there's a distinction between a 0 and 1+. With that, thank you very much.
Thank you, Dr. Shashin. Just stay on the podium, sorry. Thank you. I think that was an enlightening presentation. We need to do something in the IT with regards to the link for the people who are online. So I'll just take this opportunity to do your Q&A as that's happening, if that's okay.
That's fine.
So does anyone have, the oncologists are looking dazed. Does anyone have a question for Dr. Shaheen? I can start you off. You've
Yes.
concentrated a lot on IHC. What about fish? Because I think one of our biggest issues in the country is lack of in-house fish, the turnaround time for fish, and you can see that it has a huge implication on management.
Yeah. That's correct. I mean, you're very right. Fish currently takes about 2 weeks, right? 2 weeks from the time the requisition is made to the time the report gets out. It costs about, at least at our place, about 24,000 shillings to the patient. Currently, we are outsourcing. So we have tried severally to introduce fish in the lab so that we do it in-house. So one of the things we wanted to do, we said, okay, fine. We didn't have an immunofluorescence microscope initially. So we wanted to try out with the dual-ish, which is using a bright field microscope. The problem with that was the vendor was selling us the kit. So one test was coming to about 60,000 shillings for us even to do the test. Forget about the cost to the patient, the price. So even though we are we can do the test in-house, it's the price point. So we are in negotiations with the vendor, and we hope we can bring it in-house very, very soon. But I agree, that's a big problem.
Okay. Dr. Kiari, you look like you have a question. Okay. Anyone with a question for Dr. Kiari? Dr. Opakas?
Thank you. So who calls the HER2 low? Is it the pathologist?
The physician, the oncologist. So we give you, we provide you, we want to make sure that zero is a true zero and a 1+ is a proper true 1+. So once we do that, then and we put that narrative comment, then it's upon the oncologist in the clinical context to say that the reason why we can't just say this is HER2 low. I mean, if it's a 2+, how would we say that it's a HER2 low unless you do fish? Does that make sense? So really speaking, it has to be the oncologist to make that determination in the correct clinical context. You need to make sure your pathologist is very, very clear by saying this is a 0, meaning no staining at all, or very slight membrane staining, which is currently still 0. Less than 10% of your cells are slightly faint staining, which is now the ultra low, the so-called ultra low. Right? So your pathology should be. Now the problem, and I think there are going to be a lot more maybe assays being explored perhaps to be able to determine, because the problem with the current assays is they can't really tell you, is it a 0 or is it more than a 0 but less than a 1? It's very difficult. And that's why at least getting the low right, the 0 and 1+, that distinction should be very clear by your pathologist. Yeah.
Okay, thank you. Another round of applause for Professor Shaheen. Thank you. So we'll go to the next speaker, whom we had the pleasure of meeting earlier in the year. So our next speaker is Dr. Fashing, who's the head of Clinical Trial Unit and coordinator of the Breast Cancer Center and Gynae Onc Center at the University Hospital in Erlangen, I think, which is in Germany since 2011. And he's a steering committee member and a PI in several key breast cancer trials, and he's going to talk to us about targeting the untargeted. So welcome, Professor Fashing.
Hello, good evening. Can you hear me?
Yes, we can hear you, Prof.
Excellent. Yeah, thank you so much for inviting me. It's such a pleasure. I saw some of you I met late last year, so it's a pleasure to be here again. And it's a special pleasure to talk about the topic, and thanks for the person who picked the title, because I think it's fitting these times so well. So let me advance my slides. These are my disclosures. And talking about targets, of course, has been one of the major topics, for anybody who was developing drugs over the last 30 years. What are good targets for breast cancer treatment? And as you can see here in this slide, for a long time, we've been concerning with the gene expression, which is here in the middle. We have the basal tumors, the triple negatives, the HER2 positives, and the luminal A and luminal B-like tumors. And this is based on gene expression. And through the discovery of the human genome and the publication in 2001 and 2004, we've learned a lot about what influences this gene expression. Is it mutations? Is it copper number variations, microRNA, epigenetics, and even patient genetics? We do know that patients with a BRCA1 mutation most likely develop a triple negative tumor. So there's lots of pathways discovered in breast cancer. And the pathways that we're addressing here, mainly the knowledge that we have about those are that we're switching them off and see what happens in the cancer cell and find out, is this a good target for a cancer treatment? So switching it off, switching it on, and finding out what happens. And about 11 years ago, the pembrolizumab was approved for the treatment of melanoma, harvesting the knowledge about the tumor microenvironment and the immunology. But then now recently, there's new targets and new drugs that are pretty different from how we have developed drug over the last decades. And these drugs are targeting just molecules, mainly on the cell surface, that are not necessarily associated with the cancer pathogenesis or progression. And two examples for breast cancer are here the TROP2 and the HER2 low expression levels. But that's not the only ones. So talking about targets and what's targetable and how we do that, we have the ADCs, the antibody drug conjugates, but not only those, it's also the radioligands that are just around the corner and already approved for prostate cancer that might not need an active pathway based on the target that we're looking at. So let's turn our attention to hormone receptor positive and clinically HER2 negative breast cancer. So when I say HER2 negative, I mean the pathway is not activated. I'm not referring to any test. I'm not referring to immunohistochemistry. I'm not referring to in situ hybridization. So I just mean the pathway is not activated in a classical sense. So then for these patients, if they were hormone receptor positive, there's lots of targets and lots of drugs being developed over the last 50 years. We heard in the very beginning that Nolvadex, tamoxifen, is also an AstraZeneca product in the beginning from ICI Pharmaceuticals, and was approved almost 50 years ago. That's half a century of anti-endocrine treatment. And then in the 1990s, the aromatase inhibitors were introduced in the metastatic setting in the years 2002 to 2005, the aromatase inhibitors in the adjuvant setting. And then you can see here, since 2012, the pace is really high, where we have to, luckily, deal with new developments and new drugs that either overcome endocrine resistance or are very active through another mechanism of action. So there's these combination therapies like the mTOR inhibitor, everolimus, the CDK4/6 inhibitors, PI3 kinase inhibitors, and SERT has been approved, the elacestrant, capivasertib, inavolisib, and other drugs overcoming endocrine resistance in the PI3 kinase pathway. And you can see here in yellow are squeezed in also medications for hormone receptor positives, HER2 negatives, I mean pathway not activated, that also work. It's the PARP inhibitors olaparib and talazoparib, and TDXD, sacituzumab govitecan, and recently in the US also Dato-DXd has been approved for the treatment of hormone receptor positive HER2 negative breast cancer. So you can see that there's several ADCs already approved in the United States for the treatment that not basically mean to overcome endocrine resistance. So let's turn to how we address targets so far. And that's just like a slide, a random slide for the people that are molecularly interested in what endocrine resistance might be. And don't worry, I'm not bothering you with the endocrine pathways. I'm showing you a Kaplan-Meier curve that makes it very clear what overcoming endocrine resistance means by addressing a specific target. And that's one of my favorite slides because it was the first one that through a combination therapy here with everolimus would overcome endocrine resistance. You can see here, this is the comparator arm with exemestane, and you see a rapid progression in the first 3 months after starting the treatment, and then adding the everolimus, a very targeted therapy, overcomes this endocrine resistance, and quite successfully so. Another example, of course, are the CDK4/6 inhibitors here with the palbociclib in the PALOMA-3 study. Again, the comparator arm endocrine monotherapy, adding palbociclib, overcoming endocrine resistance quite impressively. A more recent example is the capivasertib, a PI3 kinase ACT pathway inhibitor. And here you can also see adding the capivasertib in the CAPItello 291 study to fulvestrant as the endocrine comparator. You can see with fulvestrant, rapid progression, endocrine resistant population, adding a very specific targeted therapy, overcoming endocrine resistance. So there's lots of activity in the field of understanding endocrine resistance and overcoming endocrine resistance. So what's different down here on the right side? I said, we have the pathway, we have the immunology, and down here, there's novel targets or novel treatments that don't care, is the pathway active or is it not active? It's just good enough that the target is on the cell surface. And is that a new concept? I might say, no, it's not a new concept. So just to memorize, high HER2 expression means the pathway is active, usually with good treatments like trastuzumab or T-DM1, neratinib, classical anti-HER2 treatments to address this kind of tumor cell where the HER2 drives the cancer progression. But if you would look at cancer cell that has low HER2 expression, it was already in 2015 that in sarcoma with a low HER2 expression and a therapy through a CAR T cell that addresses the HER2, and a successful treatment was established, published in a cohort from the MD Anderson Cancer Center by Ahmed et al. In the JCO in 2015. So it's not a new concept that low HER2 expression might serve as a target for treatments that work not in the classical way, addressing the HER2 activated pathway, but just using a HER2 as an anchor to direct a therapy to these cancer cells. And it seems that the antibody drug conjugates with the improvement and the specific improvements that have been done seems to be just the right candidate for doing that. So we already had that in beautiful presentations before. We have the antibody, we have the linker, and we have the drug. But I want to add one aspect to that by comparing T-DXd to T-DM1. So it's both antibody drug conjugates with different characteristics concerning specifically, of course, the payload, but also the linker. The T-DM1 is pretty strongly bound between the antibody and the chemotherapy, while the linker between T-DXd, the deruxtecan and trastuzumab, is a little bit less strong. So you hear about the bystander effect, and we heard about the bystander effect, so I'm not going to bother you with the bystander effect. I'm going to show you some preclinical data, which I usually don't do. And I showed some of you that I met last year, I showed this picture, and I hope it makes you as happy as me every time I'm looking at it, because it gives me a little bit more of information what difference might be between antibody drug conjugates and how important the specifics and the characteristics of a linker and possibly the payload is. So let's take a little bit of time, not too long, don't worry, just a little bit of time and focus on what we see here. We see on the left side a tumor that has been constructed from two different cell lines, a HER2 negative cell line and a HER2 positive cell line, and then it was stained for HER2. And in brown, you can see the nicely HER2 positively stained breast cancer cell line cells, and you can also see in between the nuclei of the HER2 negative breast cancer cell line cells. So it's a compound tumor. And then two different experiments were done. In the middle, TDM1 was given as a treatment, and on the right side, TDXD was given as a treatment. And you can see here in the middle that TDM1 beautifully removes all HER2 positive cancer cells, the ones that were previously stained brown on the left side here as being HER2 positive. But you can see that the HER2 negative breast cancer cells still remain in the tumor. And adding the TDXD to a tumor that looks like that, you can see that only fatty cells and here a blood vessel is left over after treatment with TDXD. And now we can hypothesize by ourselves how the treatment was effective enough to get from here, from the HER2 positive cells, to the breast cancer cells that are in between these islands of HER2 positive cells. So very different characteristics of TDM1, comparing it in this preclinical experiment with TDXD. I'm not going into detail with the Destiny Breast 03 study, just to show again the hazard ratio of 0.33, which is very impressive, comparing TDXD with TDM1, a huge difference with regard to progression-free survival and also the known effect on overall survival. But that's not what I'm talking about here in my talk. I'm going to HER2 low in the hormone receptor positive, HER2 negatives. And again, when I say negative, I mean the pathway is not activated. So if you're looking at the treatment landscape for patients treated being hormone receptor positive, HER2 not activated, we have some data from the real world setting from Germany. And I want to show you that and direct your attention not to the first line, but to the second line and the third line. And these are all the therapies that are given to these patients. And you can see here, after patients being nicely treated with an endocrine treatment in the first line, you can see here that the majority of the patients is treated with chemotherapy in the second line. And in the third line, there's already 67% of patients being treated with chemotherapy in the third line. And looking at that in an alluvial diagram, you can see that CDK4/6 treatment, chemotherapy was the most frequently used pathway in these patients being hormone receptor positive negative. And of course, this displays a high medical need, and we can ask the question, can we do better? And just to set the rationale for using TDXD here, let's go back really quick to what do I mean with pathway activated? And that's the original publication of Dennis Lehman from 1986, where they described the importance of what at that time already was identified as amplification in HER2, not overexpression. And that's a publication with only 63 patients. And you can see here in the nodal positives how nicely the amplification describes a group of patients where there's truly a very rapid tumor progression in that population with a HER2 amplification. For cost reasons and for practicability, we turn to immunohistochemistry to approximate for this pathway to be activated by an amplification. And we've seen these slides before. This is score 3+, which means basically in most of the cases the pathway is activated, and 2+, we have to do the FISH to see where is the pathway activated to give the classical HER2 drugs. But you can see here, even in the 1+, there's some kind of HER2 amplification. And now I'm showing you this one just very shortly one more time. And now we can think, of course, if there's some kind of HER2 expression, it might be a very reasonable thought that T-DXd works in that patient population because of the characteristics, how the antibodies and the payload are distributed in that tissue. So the DESTINY-Breast04 study summarizes these two questions and rationales into a beautiful study design. We're taking the patients that have a HER2 low expression but are classically HER2 negative, HER2 low, IHC 1 plus and 2 plus, and FISH not showing a HER2 amplification. And then these patients needed to be treated with an endocrine treatment and then at least one chemotherapy. So in the clinical setting, a typical patient would be a patient that would get CDK4/6 inhibitor in the first-line setting, and then most likely chemotherapy in the second-line setting. And then we do know that most of these patients are treated with chemotherapy again down the line. And that's exactly the question that the DESTINY-Breast04 study asks. Can we do better than standard of care chemotherapy for that patient population, comparing it with T-DXd? Primary endpoint was progression-free survival, and key secondary endpoints were PFS by the investigators and overall survival. So when we look at the number of previous lines of systemic treatment, we can see here that most of the patients got 3 or more previous treatments, and then the lines of chemotherapy, most of the patients got at least 1 line, but there's with 1/3 of the patients also patients who got 2 previous lines of chemotherapy. So this is a heavily pre-treated patient population. Just to mention really quickly, that study did not only include hormone receptor positive HER2 negatives, it also included a small subset of triple negatives in order to look for a signal in that patient population, whether it's reasonable to treat these HER2 low expressing tumors also with a treatment with T-DXd. So the targeted therapy with CDK4/6 inhibitor, and I said a typical patient would have gotten the treatment, was 70% of patients previously were treated with a CDK4/6 inhibitor, most likely, I guess, in the first therapy line. And that's the overall survival data that was shown and published for the cohort on the left side for the hormone receptor positives, and on the right side for all patients, also including the triple negatives. And while this Kaplan-Meier curve might not look as impressive as the HER2 positives, we have to keep in mind that the overall survival, once the patients progress and are heavily pretreated in the hormone receptor positive setting, that's a very aggressive disease. And the median overall survival could, in that heavily pretreated patient population, be extended by a median progression-free survival difference of 6 months, with a hazard ratio of 0.64 in the primary analysis and 0.69 solidified in the updated analysis. So that's pretty impressive. Also, the progression-free survival, of course, these Kaplan-Meier curves drop more drastically compared to the DESTINY-Breast03 study, but the hazard ratio, if you look at it, 0.37 in the primary analysis and solidified 0.37 in the updated analysis, is also very, very similar to the DESTINY-Breast03 study. So also the DESTINY-Breast04 study shows a very, very high activity of T-DXd when compared to the standard treatment with the chemotherapy that we usually would treat these patients with in the standard routine care setting. I mentioned in the beginning that also a small group of patients with triple negative was included in that trial. And that's so important because in triple negative patients, after treatment in the first line setting, if PD-L1 positive with a checkpoint inhibitor, after that, the treatment is pretty chaotic, and it's usually chemotherapy after chemotherapy after chemotherapy. Of course, with the ASCENT-03 study, we have sacituzumab govitecan, but usually these patients are having a subsequent therapy of chemotherapies that all have a very bad progression-free survival time, a very bad efficacy. So to find something that would be better than standard chemotherapy, even with shown with a small sample size, would be very useful for the clinical setting. And as you can see here, the hazard ratio for overall survival, 0.58, so a little bit smaller even than the one in the hormone receptor positive population, and the progression-free survival in the updated analysis hazard ratio 0.29 seems to point at a very high efficacy when comparing standard chemotherapy to TDXT in this triple negative patient population, even if the sample size is small. Hazard ratio of 0.29, very impressive. Looking at the subgroups, with TDXT, usually the subgroup analyses are pretty boring because you cannot identify a subgroup where the treatment would work or would work not, or would work specifically good. It works pretty much in every of these subgroups. So let's go to the next slide, which is, I think, even more important because it reflects on what we have to discuss with the patients after having started the respective therapy. On the right side, you see the chemotherapy, and an objective response is seen only in these patients here on the right side, while the majority of the patients do not show an objective response while under being standard chemotherapy. And now you can see that here, this whole group of patients up to here on the left side has an objective response. And that's something very satisfactory that you can discuss with the patients, because they do know if they get a chemotherapy, it's very uncertain whether the chemotherapy would show an effect. But with TDXT now, with the majority of patients, at the next assessment of the tumor, you will see a regression of the tumor that is objectively confirmed by RECIST criteria. Of course, everything comes at a price, and we've seen Devin nicely discussed the side effects. Nausea, fatigue, alopecia are the ones that are usually seen. And in the Destiny Best of 4 study, now we want to know what were the distribution of the ILDs. And we can see that 4 patients out of the 371 patients actually did have a ILD that subsequently tragically had an outcome of death. So just a reminder to test these patients, to listen to these patients. We had a beautiful talk from the pulmonologist. Thank you for that. I listened very closely. And that's something we have to take into consideration. But for the background of the efficacy and the overall survival benefit, including these deaths, I think it's out of the question that that's a treatment that should be implemented in clinical practice. So in the end, let's come back a little bit more on the treatment landscape. I showed you this picture, first line, mostly CDK4/6 treatment. Second line, we already see before the implementation of TDXT that chemotherapy was a frequently chosen therapy in the hormone receptor positive HER2 negative patient population. And then in the third line setting, were the Destiny Best of 4 study. So 1 previous chemotherapy and then giving a chemotherapy after that is, of course, giving TDXT after that is, of course, effectively replacing that treatment. So that's what we discussed with the Destiny Best of 4 study. And then a possible sequence could look like second line would be chemotherapy if endocrine treatment options are not something to be chosen. And then after that, the TDXT could be implemented. We've seen that the Destiny Breast 06 study in the United States has already led to the approval in the ultra-low setting. That's something that's going to be talked about in the future. But that's something that's in Europe still waiting for approval. But that might change again the necessity for a chemotherapy before giving TDXT in that therapy setting. So the Destiny Breast 06 study, just as a future outlook, might enable us to give an endocrine treatment and then go to TDXT, or an endocrine treatment, give another endocrine treatment, and then go to TDXT, because it will free us from the necessity to give a chemotherapy before this very effective antibody drug conjugate. But again, it's not approved yet even in Europe, just got the approval in the United States by the FDA. So as you can see, we're dealing, luckily, with a modern, very effective antibody-drug conjugates. It's a new substance class that, because of their characteristics, being bound to an antibody and then cleverly, kind of smartly being released in the tissue. We've heard about the characteristics in the brain, with brain metastasis. Now, even in patients that don't have a strong HER2 expression pointing at the activated pathway, just the presence of HER2 seems to be good enough to direct that therapy into the tissues where obviously the pharmacokinetics lead to a high efficacy. We always have to be aware of the side effects. It's something that you always have to have your guard up. Don't let your guard down. I heard you got 14, 15 patients, and it's just until the patient where you got a side effect, where you got an adverse event where you have to pay attention to until it happens. It usually happens at some time point. So it's like always be on the outlook, always be careful with regard to these side effects. And for that, you will have many good discussions with the patients, looking at the efficacy, being happy together with the patients that you see tumor shrinkage after starting the therapy, very similar to the HER2 positives. So it's definitely something that is an enrichment for the therapies in your portfolio in the clinics. And with that, I thank you for your attention. And I remember again the Kenya visit last year. I'm talking a lot about it. It was very nice to have met the ones of you that I met. It was a very nice day. So thank you again for the invitation to be here today, and thank you to AstraZeneca. Thank you.
Thank you, Prof. Fashing. Again, a very eloquent presentation. I think you really covered many of the questions. Is Dr. Oyero still here? I think he had asked about ultra-low, and we have covered quite a bit about that. So in the interest of time, we still have a panel discussion. So I will call Dr. Elena Musau, who is the past president of KESHO, and she's going to be leading the panel discussion and then a joint Q&A. Welcome.
Thank you very much, Sitna. I'm looking around and I'm seeing a lot of tired faces. I'll ask you all to stand up. Just give it a stand. Are we all up? Great. So I just want you to make a Y with your hand. We're not doing the YMCA. Just imagine, that's how Herceptin looks like, with 8 molecules on it for chemotherapy, the payload. Now shake it all around. Great, now you can have a seat. Excellent. So we're on to our final session for this evening, and I want to thank all of you for hanging on and staying here with us as we wind up this conversation on HER2. We want to talk a little bit about the policy and what is there for cancer care in Kenya. And so I'd like to invite onto the stage Dr. Oluma Oluga. Dr. Oluma Oluga is a recipient of the Order of the Golden Warrior. He is a director and the head of the Directorate of Health Sector Coordination and Research Development at the Kenya Ministry of Health. He has more than 15 years experience in executive and strategic leadership in the health and workforce sector. So we'll want to hear from you today, and we invite you to this panel. Our second panelist, who is unfortunately not able to be with us this evening, is Dr. Elias Meli. He is a medical and radiation oncologist. He holds a master's in clinical oncology and nuclear medicine from Alexandria University. He is the Chief Executive Officer of National Cancer Institute of Kenya, and also an entrepreneur and founder and CEO of Alexandria Cancer Centers. So karibuni sana. I'll start off with the WHO Africa region report that we got recently that ranked Kenya as the top in sub-Saharan Africa, or in the Africa region, followed by Nigeria and Algeria as being the best in cancer control. They were looking at leadership and governance, health workforce, health medical information systems, and service delivery. And they saw that Kenya, in terms of service delivery, was one of the best equipped countries for cancer care. We, however, still see quite a number of patients presenting with advanced disease in Kenya. And so I'd like to ask, what efforts is the ministry playing, and what efforts is the National Cancer Institute of Kenya making towards improving early detection and treatment of breast cancer in the country? Thank you.
Thank you, Madam Vice President, and good evening, colleagues. So I think Professor Meli, if he's online, I think is best placed to discuss the content around cancer and the policy. I think there's been a lot of very heavy discussion. I've felt very intellectually tortured this evening, but I believe that it's all for the good. For us, just to paint for you the picture of how policy is made. One is that health does not belong to the Ministry of Health, and I think that is something that needs to be said more and more and more and more, because the perception that is out there is that it is the Ministry of Health that must do it. Yes, the mandate belongs with the Ministry of Health, but it is all of our responsibility, and that is why there is a directorate called Health Sector Coordination and Research Development, which I am privileged right now to be the director. And we look at engagement as a key principle of policy formulation. And one of the key things is the 4 areas of how we engage. One, with, of course, locally, intra-country, with our county governments, and then internationally with the foreign governments. And then, of course, the sector has a lot of players, and that is the development organizations, the World Bank, the WHO, that has been mentioned, and also the international NGOs, the philanthropies, basically everyone in the development space. And then lastly is the private sector. And the private sector is where organizations such as the AstraZeneca and all of these pharma manufacturers, all of them fall in that. And our work is really to coordinate for 2 things. One is to align the policy, and number 2 is to enable, so that we enable you to achieve what you'd want to see in the policy. Because, and I think Dr. Meli may speak to this, when we talk about the policy, policy is usually a compromise of what people want. And so there must be those people who want it. So today you're discussing novel treatments, HER2, and even other molecules that could be used in the treatment of cancer. So that's where it starts. It starts by people who want something, either patients or the professionals who represent the patients. And then there is that engagement. That is our work to facilitate. And then, of course, there is the issue around the resourcing around it, and then whether that resourcing balances with the competing interests. And that compromise is what is called policy. And I think that, to me, is the most important thing to highlight tonight, and that we are available to engage. Of course, Kenya has moved quite a bit in terms of, we have a national cancer policy all the way up to 2030. We have the national cancer management strategies. We have, of course, the cancer management guidelines. And then, of course, even for breast cancer specifically, there is an action plan, especially for screening and early diagnosis. And I believe that all of these are tools that came from yourselves. And when it comes to some of the products, including the novel products that we are looking at, of course, we have the Kenya Essential Medicines list, and there's that engagement that gets all of these products into the Kenya Essential Medicines list. There's also the Kenya Essential Medical Supplies list, and then there is, of course, the other engagements that ensure that diagnostics are available, and this is all your work. It's not actually the Ministry of Health's work. And for us is to provide that platform for you to engage. And of course, then at the tail end of it, in terms of financing, will be the costing and the issues around insurance and whether they are covered in the benefit packages and not. So I think that's where I want to stop in terms of this engagement. And I know that my colleague, Professor Meli, would be talking more about the specific cancer-related policies. Now, policies are domiciled in the directorate or the divisions that are engaged in that discipline. So, for example, reproductive health policies will be more domiciled in the reproductive health or the family health directorates. The cancer policies will be more domiciled at the cancer policies. And our work, my work specifically, is to bring everyone together in terms of that policy discussion. Thank you.
Thank you. And maybe as we wait to get Dr. Meli's comments on the same, in terms of the referral networks and pathways that we have, we see a lot more cancer centers in urban areas. How are we looking at it from, countrywide in the rural setup? What would we be able to do to improve screening, early detection and treatment as we look to improve outcomes using targeted therapies?
Three things. One is, of course, everything, and I mentioned policy as a compromise. So when we talk about compromise, we look at equity, and equity in terms of access, and access is not just access to treatments like what we are discussing today, but also access to information in itself, access to people knowing how they could be screened, how they could get early diagnosis, access to oncologists like yourselves, access to rehabilitation after that. And one of the greatest challenges I think that we face, even though you've mentioned the statistics about us being better, one of the challenges that are there right now is access to information, actually. So that is the greatest challenge that the country is still grappling with. Across all the spectrum of all cancers, there's a big challenge for information. And this information is in two parts. One part is the general public perception around healthcare, and therefore people doubting some of the diagnosis that they get, partly because of stigma, but partly because also of the diagnostic challenges within the healthcare system. And the second bit about this is the capacity within the health workforce. I think you can tell that oncologists, whether surgical oncologists or clinical oncologists or radiation oncologists, or the specialists or the capacity of the health workforce that specifically have knowledge of cancer is minimal across the health workforce. So this in itself also causes a lot of knowledge gaps, because we have a lot of patients who go before healthcare workers, but before they get confidence that what they are dealing with is cancer, they have to visit hospitals, I think almost 7 times. And this is already a challenge. So as a country, that is the biggest challenge. So even as we talk about inequity in access, what we are still grappling with is the inequity in information. And so we are basically 3 or 4 steps behind even discussing what you are discussing today. So you will see that most policies are heavy on enabling communities to engage, to reduce stigma, to access information, to go for screening, to go for early diagnosis, before we even talk about the real treatment and the real diagnostic ecosystems. So I think that's the thing that I'll talk about. And mentioning that, it's really a collaborative effort, and that's why we believe that participating in this kind of forums are very useful for us. And there's this other bit about the research development, which is basically the evidence that comes to policies. Most of our policies also need to be evidence-based, and some of that evidence should come from research. And I think there's very little of that research right now. There's a lot of scientific-based research, but there's very little health systems-based research that then can inform policy. So most of our policies are based on consensus rather than evidence. And I think that is a challenge that I want to put to you, that we need to move more towards evidence-based policies rather than consensus-based policies, because we have this a habit in the country where we invite everyone in the room, irrespective of how much knowledge you have. It's more about how many people are in the room and what they agreed about. And I think this is a real challenge to the professionals and to yourselves, that you should be putting evidence out there that cannot be refuted, that is so powerful that the decisions that go into policy cannot be an alternative other than what the professionals think it should be.
Okay. Thank you very much, Dr. Ari. And maybe, Karibu, Dr. Melu, and thank you for joining us. I could ask you, just chiming from what Dr. Oluga has said regarding evidence-based policies. We have our local cancer treatment guidelines. Are they evidence-based, and what efforts is NCI using or looking at to improve the treatment guidelines, also looking to provide standard of care for Kenyans? We can't hear you. Yes, we can see you. We cannot hear you. Unmute. Please bear with us. He's unmuted.
I am unmuted.
There you go.
Am I audible now?
Yes, you are. Go ahead, Dr.
Oh, thank you very much. Thank you, Helena, for moderating this session. I want to appreciate all the speakers that have come before. I know it's deep late in the night, and I'm very sure the participants are quite fatigued. Mine is going to be very short. I appreciate the science that has gone into us tonight. As a practicing clinical oncologist, definitely there's been a lot of learning from all the speakers, from basic sciences to clinical practice and all the research that has been undertaken before. Mainly work with Moi Teaching and Referral Hospital. And I'm glad that we are discussing novel therapies that is as a result of evidence-based research. We have been taken through all the trials over different milestones achieved over several decades in HER2 setting. And this is a reflection of what's happening across all the cancers. Breast cancer has been leading the way, definitely, because it is an area, a cancer of interest, being one that has the leading cancer amongst all the cancers, let me say in females in this case. Therefore, there is so much interest from everyone, from government, from industry, from pharma, and also civil society as well. So specifically to your question, I join all the colleagues who've spoken to appreciate the efforts that has gone into the outcomes of cancer care and breast cancer specifically, and also appreciate all the stakeholders involved that saw Kenya be ranked the best in Africa in breast cancer prevention and control. This was an outcome of course, through the leadership of the National Cancer Institute of Kenya, providing leadership and governance, but this is really as a result of efforts of everyone who is in this meeting today and those who are not there, who are involved in cancer prevention and control in the country. Now, from research, definitely, from a government perspective, we utilize research in two ways. Number one, in policy development. And my good friend, Dr. Luga, has talked a little bit about how we can use research to inform policy. And once a policy has been formed, definitely there should be guidelines, that is going to operationalize most of these policies. Or this research output may also directly go into influencing guidelines. And as a country, one of the functions the National Cancer Institute of Kenya has is to make sure there is quality cancer care, across the entire continuum. And specifically today, we are talking about treatment of diagnosis and treatment of breast cancer with specific reference to HER2 and the targets. Therefore, it is with this information that we use to streamline the guidelines that we are using in treating breast cancer. As a country, due to what I think I'd been asked earlier on, how many Africans participated in most of these clinical trials, and clearly zero. I'm happy that we've now achieved milestones, and locally within the country now we are able to participate in clinical trials, looking at the center at Aga Khan and the center at University of Nairobi, and also we have a center at Moi University, Moi Teaching and Referral Hospital, and soon the National Cancer Institute of Kenya will also have a clinical trials unit. So there is more investment that has gone into that, and certainly soon we shall be participating in these clinical trials because we are an area of interest, since we do understand with precision oncology and appreciating the different diversities and health disparities. It goes all the way to genomic disparities, without which, if we don't participate in these clinical trials, we cannot be sure whether we are treating our patients, with we could be under-treating or under-diagnosing, or over-treating or over-diagnosing our patients based on foreign data. So to answer your question directly, yes, we have treatment guidelines, but they may not be informed by locally generated data, but informed by foreign data. We've previously had NCCN guidelines for Sub-Saharan Africa, and I know Kesho and other stakeholders have participated in this, including the National Cancer Institute of Kenya. And I'm happy that soon, in another couple of years, we should be able to discuss now guidelines informed by our locally generated data. That is going to be precision oncology now for our patients within the country. I want to believe that all of us who are treating oncologists, we have these guidelines. Unfortunately, it's been a big challenge to enforce these guidelines or protocols, across our treatment cancer centers, because most of us are trained, from different institutions across the world. And I'm happy that we have a training program also within the country, at fellowship levels and also at masters now at University of Nairobi for specifically the oncologists. I know there are training programs for pathologists as well and other disciplines. So I want to believe that with the evidence that we are discussing here today, it should standardize our care. And we are reviewing these guidelines from time to time. This year, we are actually going to review most of our major cancers guidelines and protocols for treatment. And I want to invite all of us to participate when you are invited, because this is the only way we can standardize our care and improve our, our outcomes. And it is the only way as a country we can be able to reduce the burden of cancer care. I also want to allude to, for us to standardize care, we must also have, standard or current equipment, infrastructure-wise, all the way from capacity in our pathology departments, infrastructure, human resource, as well as the reagents and commodities that we are using, in diagnostics. At the same time, we should also be able to have access of human resource for treatment, across all our treating cancer centers, and continuous professional development, continuous medical education, so that we are all able to update ourselves on the guidelines, on the latest cutthroat research that informs treatment for our patients. Those would be my comments, Dr. Elena.
Thank you very much, Dr. Melly. I'm seeing we are really, really pressed for time. We've run almost an hour beyond our program. And so I'll ask Dr. Oluga in very few comments to tell us how we can engage to create that enabling environment where we can see government working together with the healthcare professionals, working together with industry to ensure that we get standard of care for our cancer patients and we continue to rank top in the WHO Africa region.
Thank you. I think much has been said. So just in summary, one is that it's basically you have to take the responsibility back on you. And that's how things have been done throughout history in any government. There is always that group of people who feel responsible, and you feel responsible for the space that you practice. And I think in a nutshell is that you must make sure that you're applying your knowledge and you're applying it for the benefit of society. There is no one within government that has the knowledge that you have. That's how you have to understand it. Yet the patients need this knowledge, the patients need the tools that you need to apply that knowledge, the patients need all of this product. And so in this constant negotiation, or to produce an equilibrium, there is always some consensus, because resources are not infinite. And that's really the challenge. If resources were infinite, there would never be an argument about what a policy is. There would never even be policy. It would just be, this is what needs to happen, and it happens. But because resources are not, they are not limitless, there's always a limit, so there has to be that engagement, and there has to be a balance of what is it that we can't do without. And I think that's the understanding that we need to come out with in this room. So every time you're looking at the cancer, whether it's the screening, whether it's the education, whether it's development for human resource, whether it's engagement with the private sector organizations like AstraZeneca and others, including local manufacturing and all of these entities that can make sure that these products are available, researchers, you always have to look at what is it that I can't do without. And that question can't be answered by government. It has to be answered by you, because that eventually is what makes the guideline, that's eventually what makes the policy, and that's eventually what makes your work easy. Because at the end of the day, you must practice in an environment that is fulfilling, not just for you and for your careers, but also for the patients, that you want this knowledge and these products to help. I think that's where I leave it. Thank you.
Thank you very much. And to Dr. Melly, your parting shot, and also looking at how, NCI would augment patients' voices to make this journey or this work more impactful.
Thank you very much. Well, picking from Dr. Luga's comments, it is the reason why the National Cancer Institute of Kenya exists, to coordinate and also provide leadership into cancer care. And coordinating means rallying everyone towards one call: reduction of the burden of cancer in our country, towards all the possible initiatives that we can deploy across the entire continuum of care, from prevention efforts to screening for early diagnosis, proper diagnostics. It is sad that as a country, even when the world is embracing now novel therapies, that can only happen if we are able to do proper diagnostics to a level of, from public facilities where the access can be possible for everyone, be able to, conduct molecular diagnostics, whether through NGS or WGS. And I want to thank Professor Shaheen for leading the efforts of making sure there is better diagnostics for cancer, because without that, even with all the beautiful drugs we are discussing today, it's going to be in vain if we are not able to, with quality, be able to diagnose. And we come in as a government agency to rally and to make sure we provide, guidelines, and we provide guidance to make sure all the pathology departments in our academic institutions across and our hospitals across the country, as well as in private sector, are able to diagnose properly and also provide treatment, for the centers who are treating with curative intention, as well as palliative care, where we know most of our patients currently benefit from this. You've talked about patient voices. We have patients now who, it's the reason why all of us are gathered here this evening. It is the reason why we conduct all this research. It's the reason why we get challenged and try all the time to provide what would address the current challenges that we have. Therefore, we have to listen to their voices. We have to convert all the scientific efforts, all the cutthroat research that we are conducting within the country and without, into responding to their challenges. More often than not, we have forgotten that their voices must be heard, and they must also participate in these clinical trials that we are conducting. And I know currently the guidance is every clinical trial must have patients' voices in it. And we will also, from the government, perspective, champion for that. I know one challenge with patients is going to be the cost of these treatments. It is true that we have very novel drugs that are going, to treat patients who have metastatic disease, into complete remission. We have seen all the beautiful outcomes of all the trials that we've been taken through, whether it's Cleopatra, whether it's Amelia, whether it's Dresser, or even the TDXT that we are discussing right now, with all the overall response rate, with all the progression-free survival. This data is with us. But what does this mean to the patients when they cannot afford these drugs? So from a government perspective, we all know that as a country, there is so much that is going on currently in healthcare financing to make sure the patients can afford these drugs. I did my homework, and I appreciate, AZ for these molecules that are available now, but looking at a cost of, per cycle between 350,000 Kenyan shillings to 400 and almost 70,000 shillings per cycle, every 21 days. Of course, the cost is still going to be a challenge, but I want to believe that we'll have a discussion on how we can get access programs so that our patients can afford this. We have talked about how having clinical trials is one way of access for these molecules, but the patients who would have an indication for this, drug is more than those who would participate in a clinical trial. So unless we have sustainable ways of making sure these are anchored in our benefits packages through our social health authority, it is going to be a tall order for our patients to afford these very, very life-changing and life-saving molecules. So I want to believe that that discussion will begin immediately in our offices after this launch today, so that our patients can access this treatment and others that we know currently are indicated based on our guidelines, which are evidence-based. Thank you very much. I would wish to end there. I know it's late in the night, And reading, of course, the mood of the participants, it's only fair that we bring this to a close. Thank you very much, and I want to appreciate AstraZeneca for supporting our government efforts always, like the other stakeholders that have been part of our successful journey in cancer care in the country. And my apologies, I could not join you physically today. Have a good night.
Good night. Thank you very much, Dr. Melly. Thank you very much, Dr. Oluga. This conversation has sparked some interesting and important ideas, and we need to continue this conversation further. Tonight may not be the best place to do this. We started this conversation at Kesho, where we had a meeting between Kesho, facilities, industry partners, the Ministry of Health, and it was all led by Dr. Melly at NCI. And so we hope that we will be able to continue these conversations in future. We've had very interesting deliberations, and I know we shall continue with them. But to help us wind up this evening, I'd like to invite Brian.
Thank you very much, Dr. Elena. Thank you to all participants for joining. So just before we close, we'll have Bernard, our Market Access Director, to close the meeting. Then we can have dinner right across. Thank you.
Thank you very much. It has been a great evening, although it has been long. Let's appreciate ourselves for staying this long. I think the greatest challenge as has come from this meeting is access to this innovative treatment. We take it within us that we have to make efforts to have these products, this innovative treatment to our patients. Our first move has been to avail this product in the country at 50% of the cost that the patients would have gotten it elsewhere. That still might not be accessible to all the patients as we rightfully would want. However, there are efforts from engagements with government, that is SHA, engagements with Dr. Melly. We have planned these discussions, and we are going to see how all of us can contribute to lowering this price, making it affordable to most of our patients. But in the meantime, let's give this benefit to our patients. Let's select the patients who can benefit from this rightly. And I'm sure the benefits, as has been highlighted by the able faculty, can be translated to our patients. Asanteni sana. Thank you so much for coming. We really appreciate your participation up to this late. Bon appetit.